This conference will now be recorded.
Good morning, everybody. Today is Saturday, December the 7th. Welcome to the live section, NCLEX review. Today is module 8, pediatrics. We're going to be dealing with some systems and specific conditions. This is powered by the NERC, and Lynette Blair is the instructor, and I'm Dr. Kennedy. I'm the facilitator. We have given some announcements, and on the hour we'll also provide more. Stanton will come in to provide some announcements. So let's get started today. Again, if you have any issue with the audio or the slides, please let us know. So we're going to start today with the respiratory system. Let's start with a note that usually I like to put in red so that it's easier for you to pick up. Children with respiratory disorders should be monitored for weight loss and for signs of dehydration. Signs of dehydration include sunken fontanelles in infants, non-elastic skin turgor, decreased and concentrated urinary output, dry mucous membrane, and decreased tear production. The first condition we should and again, this summarizes a lot of what we will be dealing with, because respiratory disorders tend to flow into each other. And of course, the major thing we see here will be that we need to quickly, this is usually an emergency in certain cases, but once you want to follow the ABC rule, it means that you have to be quick to take care of respiratory symptoms. Epiglottis, this is an emergency situation. It can progress rapidly to severe respiratory distress. Children immunized with H influenza type B vaccine are at less risk of epiglottis. Again, to explain why vaccine preventable diseases or vaccine as a whole is important, because depending on the type of vaccine, it offers protection. It's a form of it's a bacterial form of croup. It often occurs in children 2 to 8 years old, but also from infancy, even up to adulthood. The onset is abrupt, and as you can see, because it's the epiglottis, is going to block the passageway as well. And the condition often occurs during the winter time. So in the assessment, you're looking for of course, most of these conditions come with fever, so sometimes we'll gloss over fever, but when it comes to very high fever, nausea, or vomiting, when there's a distinction, we'll talk about that, but we'll gloss over. We have a lot of slides to go through, but most of it, as for information, we'll post them on the site, and you can go through them to help you improve your skills. Now, in this case, you will have if you look in your book, this is the 7th edition, rather. If you look in your book in box 39, you see a characteristic sole red inflamed throat that is cherry red, and it can be edematous. There's an absence of spontaneous cough. This person just cough. They start to lose their voice, get very dyspneic, and they start to have a stridor inspiratory. See the breathing start to get really laborious, and tachypnea, even tachycardia. Obviously, these things run into each other. Their position start to be tripod. Oops, what happened? Okay, I don't know what happened here. Again, the intervention, you want to make sure, and the reason why you see this from the beginning for the airway, most of what we're going to be dealing with respiratory, you have to have patent airway, you have to make sure you humidify oxygenation, you have to make sure you have less environmental stimuli because the person is under stress. You control fever, you give medication. So most of it look like, they're about the same. In this case, you have to note nasal flaring and use of accessory muscles retraction. If you look again in box 39.2, you will see this parts on the chest that tells you about the location of retraction. You literally see the person look like their chest is going in, but a specific part from the neck area, the ribs down to the intercostal and the abdominal area, you see that they are struggling to breathe. Do not measure temperature by oral route at this time, because part of it too, you have to look at it. You could be introducing infection. The person have to be meeting MPO. Don't leave the child unattended. Place them in a supine position. Of course, do not restrain. Even they look like they are under stress and restless. You have to provide options to help them to be calm. And again, the treatment options and emergency care are outlined that you have to follow. I'm not sure what's happening. So I'm creating slides that I don't have. Oh, I see why. I see where the problem is. I apologize. I should have put this on the larger screen. Okay. Is it better now? The screen is bigger? Okay. So,
It's better.
Okay, good. I apologize. I see why I was creating slides. And if epiglottis is suspected, no attempt should be made to visualize the posterior pharynx. Obtain a throat culture or take an oral temperature. Otherwise, spasm of the epiglottis can occur, leading to complete airway occlusion. The reason why you see some of these hints for, as a student, you're going to be much more concerned about taking your NCLEX and passing. We wish for the best for that. So when you see some of these conditions, it should stand out to you. What are things that you should not do, or something that specifically stands out that you should take note of? This is one of them. Once you suspect, so if they ask you a question that if there's, for example, if you suspect epiglottis or you suspect someone having certain kind of condition that will be highlighting, I don't want to kind of jump ahead. What are things that you most likely should not do or you should least be doing? These are things to stand out to you. Now, laryngobronchitis. In this case, all three of the larynx, trachea, and bronchus are inflamed. It's the most common type of croup. It can be both viral and bacteria. It's a gradual onset and may be preceded by other infection that you may have had, that the child may have had. And if you look in box 39.1, it provides, depending on the stages. So for example, you have stage 1, in which is low-grade fever. At that time, you see that the child starts to have hoarseness, seal back and grassy cough. And they look that they are such fearful. And we talk about inspiratory stridor and even including the retraction. But as they become irritable and restless, if it moves to stage 2, you start to see that the respiratory stridor starts to become even more pronounced, and accessory muscles start to be used, and it looks like their chest is kind of depressing, and they are struggling to breathe, really becoming laborious. And at this time, the reason why you see some of these respiratory conditions start to run into each other with restlessness, with diaphoresis, with becoming pale and blue, is because the person is struggling so much and they're losing up all their energy. This is why you as a nurse have to be around with the family to do some teaching, so that as you give medication, you calm them down, you create a comfortable environment. Crackles and wheezings will start liberal respiration. If it moves to stage 3, you start to become really restless. The anxiety from fear of what's happening, you become really anxious. Because imagine you're going out of breath. They get very diaphoretic and anorexic. As it moves to stage 4, at this point, the cyanosis start to kick in from intermittent to permanent, and they become apneic. And in this case, they are progressing to respiratory cessation. Now, the intervention, obviously, in this case would be to make sure you assess the respiratory status as you did during the assessment, and do pulse ox, monitor for nasal flaring, because once you start, it's becoming an emergency. And if you look at box 39.2, it outlines those things that you are supposed to do in the assessment. The monitor for adequate respiratory exchange, monitor for pallor and cyanosis, elevate the head of the bed and provide rest. A highlighter, as you can see in the, to provide humidified oxygen, so that this will be helpful to provide, to go through a cool air and mist tent, depending on how much. If the child is in a hospital, usually they put them in the tent so that they can be able to have humidification much better. And as you can see in the assessment in box 39.2, it will lay out a lot of those to do depending on the initial manifestation. As the manifestation moves forward to disease, as the disease progresses, in the assessment I explained to you about the stages, and you start to see when it starts to get severe, the breath rate start to be like more than 70 times per minute, which is really becoming a problem. And if you look at box 39.1, this would be helpful for you as you're reading to be able to discriminate some of the things that you have to separate between oxygen mask, nasal cannula, oxygen tent, and the oxygen hood or face tent. This will help you to know how much the advantages and disadvantages in terms of, for example, how much percentage of oxygen is provided. A lot of time in your practice, you're going to have sometimes you're going to have a machine that you have to calibrate or that has already been calibrated. But if there is a problem, you have to help to know what should be the percentage. Often it's listed. The respiratory therapy should be, but if you are on a night shift and there's none, you have to figure it out. Now, for laryngotruncal bronchitis, isolation precautions should be implemented for a hospitalized child with an upper respiratory infection until the cause is unknown. So let's move on to bronchitis. In this one involves both the trachea and the bronchi. Often they are called trachobronchitis, unlike the one previously that had a laryngeal associated. And here it's associated with an upper respiratory infection. It's usually milder and most often viral. So in this case, you can see at some point the treatment going to be symptomatic and palliative depending on how it progresses. As you can see, the cough become hacking like a dog, in that way, and it's non-productive. It worsens at night and productive in 2 to 3 days. In the intervention will be symptomatic. Remember, this is a virus condition. Always start to think about virus condition as, unless there's an infection that kicks in, that they are often going to be treated symptomatically. Nowadays, we have antiviral medications that help with conditions from common cold to flu, but you have to often think about it as a virus, and the more you try to be aggressive, it can cause more problems. Cool, humidify air, increase fluid, antipyretic, and you have to give cough suppressant. Always be careful with cough suppressant unless you have, especially you have to have an order to be able to do this, because some of the respiratory condition, you have to be careful suppressing the cough at some point, while you also have to do a holistic treatment in this case. This is one condition we should take note of: bronchiolitis and respiratory syncytial virus, RSV. In this case, the bronchioles, as many of you know, the bronchioles are the smaller bronchi. When they separate, then you have the bronchioles. They actually, as the anatomy of the respiratory tract becomes smaller, the anatomical structure, they become much more important in the gas exchange. Now, when you start to get to the bronchioles and the alveoli, that's where the actual exchange is about to occur. Now, if you have a condition that attack those areas, they become much more pronounced because they are the right aspect of where the gas exchange start to take place. So the bronchiole leading to thick mucus, and because they include the bronchiole and the smaller bronchiole, that's where the symptoms start to arise. Acute viral infection is not airborne. Take note of this. So as you're doing your little cheat sheet, take note of that. RSV, they are not airborne, but they are highly communicable. So it's one of those things that you say, okay, it's not airborne, but how is it communicable? Because it's usually transferred by direct contact with respiratory secretion. And, it's not unusual. Many of us, including when you are busy out there, you touch something and then your nose is itching and you touch that and you yourself get it, or other children who plays get that. Prevention, as it lists here, from breastfeeding, avoiding tobacco cessation. As we see in many respiratory conditions, especially with children, there's a lot of trigger with tobacco exposure. This is why now from TEV exposure, secondary smoking or even tertiary smoking exists from the clothes on the parent, or even those that come to visit, or even if it's your children, someone that come to visit, they will be exposed to tobacco smoke, and that can be a trigger. Of course, hand washing. Remember that everything we're going to be doing is if there used to be a professor way back who said that if you have nothing to do in a hospital or in your facility, you just keep washing your hands. So everything has to do with hand washing, especially with all these conditions we have now, from MRSA to E. coli to C. diff. The best thing you can do to keep washing your hand, as much as sometimes washing hands may not completely remove, but it can help you to reduce your chance of infecting not only others but yourself as well. And medications are administered. Palivizumab is given to high-risk children and is administered IM, usually monthly for 5 months period, often between November to March. If we look in box 39.2, it lists out our assessment of RSV from the initial manifestation to the disease process and the manifestation in severe illness. Sorry, that was what I was referring to earlier. I jumped a little bit. Here you start to see that respiratory count start to really become tachypneic up to 70. And as it progresses from rhinorrhea, which can be hard to differentiate because in your differential diagnosis, sometimes you see many conditions with a runny nose. But as it starts to progress, you start to see about air hunger. Those are really things to start to look at emergency. And once the cyanosis start to kick in, the next thing you start to see a person get very restless and listless. The intervention for RSV and bronchiolitis is, again, because virus connection, symptomatic, you have to isolate or share a room with other children who have, or another child with RSV. You that providing the care should not care for another high-risk person, because you definitely going to spread out. Good contact and standard precaution. Again, we talk about patent airway, cool humidifier air, and oxygen should always be available as ordered. And just to let you know, as a nurse, there will be time where your judgment is that you have to provide oxygen for someone, even if they have DNR. There will be a time that you have to provide oxygen until you can be able to get an order. There's a difference between providing an emergency service unless it is explicitly listed. So a lot of time, this is why you always have oxygen canister next to your crash cart in case you need it. The most effective airway maintenance position the child at 30 to 40 degree angle with neck slightly extended to maintain an open airway and decrease pressure on the diaphragm. Even in the set of respiratory conditions that we'll be talking about, a lot of time we'll talk about positioning. It has to do with how much you can position a child to be able to assist themselves to breathe, and also to be able to reduce the chance of, say, obstruction or the neck contributing to, depending on how stooped over the child is or lying down in what position. So putting it in a certain reclining position can be helpful. So think about it as most time one of your first instant about airway. Maintaining a patent airway has to do with positioning, unless you have certain conditions such as head injury or bike injury or spinal injury, where you got to be careful with certain position. In those cases, you will get to know, be explicit to know that you have to keep the person in this position. You may have to suction. Remember, we talk about fluid accumulation, and ribavirin is an antivirus medication. Now we have a lot of them on the market that are used for some of these conditions. I don't see any comments so far. So far, it's me alone. Let me just take a quick look to make sure nobody. Okay, I see up here. Okay, so no comments so far. Now, for RSV and bronchiolitis, cough suppressants are administered with caution because they can interfere with the clearance of the respiratory secretion. This is why I said earlier, be careful with cough suppressant. Sometimes they are good, but sometimes they may delay certain kind of treatment regimen. So in this case, if you try to hold back cough too much, sometimes you can interfere with clearance of the secretion. So, sorry. All right, let's move on to pneumonia. It usually affects the parenchyma or alveolar or both, and it could be virus, which is most often, or other agent, mycoplasma, bacteria, aspiration, or foreign body. The agent usually is introduced into the lungs through inhalation or from bloodstream. Now you have primary atypical pneumonia, which is usually caused by the mycoplasma pneumonia or chlamydia pneumonia, or you have the strep, which is most common. Aspiration pneumonia, as you know, states out, is a classical symptom, increasing cough or fever with foul-smelling sputum, because usually the child, or even in the case of adult, if you want to look at it, will have aspirated of some food product or some article or something, and so you have this foul-smelling. The deteriorating result on chest X-ray and other signs of airway obstruction. Prevention of viral and bacterial pneumonia include immunizing children and infant and children with the bivalent pneumonia conjugate. For the assessment, you have to assess the pneumonia based on whether it's viral, atypical, and bacterial that we just listed. Let's move on to, and for those of you, like, for example, the atypical, I'll just go back a little bit. For the viral pneumonia, the onset is usually acute or insidious, and the symptom can range from mild to, mild fever to malaise, and you have wheezing and crackles, and the intervention could just be symptomatic because it's viral. Of course, we talk about oxygen, we talk about positioning, chest physiotherapy, posterior drainage, antipyretic. In the atypical pneumonia, is when it can be acute or insidious. In this case, fever will last for about 2 weeks, and the child will have sore throat, that's rhinitis, productive cough, and the intervention will be symptomatic. Recovery is usually 7 to 10 days. In bacterial pneumonia, that's when it becomes, like, depending on the age. If it's an infant, you will see different symptoms. Older adult, you will see like headache, chills, and you have hacking, productive cough, diminished breath sound, and as a move on, as the infection resolves, the child becomes productive and the child expectorates purulent sputum. Be careful with purulent sputum to know the color. You usually have to note the color in your note so that you are able to discriminate what it is and differentiate it. Of course, the intervention of bacteria will be antibiotic, again, oxygen, cool mist, suction if possible, chest physiotherapy or posterior drainage every 4 hours if needed, and of course you want bed rest. In every case too, another thing you should add is that these children need adequate nutrition. Asthma. Asthma is chronic inflammatory disease of the airway. is usually classified based on the severity. So as a result, if it has to be managed with medication, it has to be managed through exposure, you have to look at a holistic way to look at asthma as much as we have to manage the symptoms. But there are environmental control of allergen we have to do, and the child and family education. Some of the asthmatic attack that we see are a reaction in the airway caused by precipitants. So depending on what exposure you have, this is why children or even adults or anyone who has asthma tend to have these reactions when they are exposed to precipitants. And it can lead to an immediate reaction with obstruction occurring. And it can result in late bronchial obstruction reaction severe several hours after the initial exposure. So the person coming in and they start to have these symptoms, but actually it started from somewhere. Mast cells release of histamine leads to bronchial obstructive process. Sometimes you'll be asked if you have alternative questions to sometimes explain some of the rationale why something happened in the order. So conditions like asthma that are quite common and that most likely you will see in the NCLEX, you have to sometimes understand how to explain what is happening. And so be prepared to be able to say that in the pathophysiology, for example, this is what you expect in order. And in this case, for example, when mast cells are released, it leads to bronchial obstructive process, that leads to bronchospasm, and that leads to obstruction. And then the person starts to have all the symptoms. The diagnosis, therefore, is made on the basis of a child's symptoms, history, and physical examination. Sometimes they have to do chest X-ray to be able to do and laboratory tests. If you look in box 39.3, they have pulmonary function tests from spirometry, down peak, expiratory flow rate measurement, broncho provocation testing, skin testing is done to identify whether they have specific allergen. Because I've had experience doing this for more than 25, 27 years, that some of them you can give all the medication, the attack comes right by. In fact, you become fearful that if you give more medication for the asthma, they start to have more symptoms because you get very woozy, and then only to realize that this person was being exposed to an allergen. So this is why you have to usually make the environment as neutral as possible, because you may just be the one causing the problem or the environment. Exercise challenges is used to identify the occurrence of exercise-induced bronchospasm. I mean, these children should also have the ability to exercise or do things like normal children, but when they start to have certain kind of trigger, you can limit their exercise activities or get to know whether it's the environment again. And other tests are done. Now, for precipitant may trigger an asthmatic attack, as we see in box 39.4, from allergen, outdoor irritants, tobacco smoke, exposure to occupational irritant, exercise, even extreme of temperature, cold air, environmental changes as they move from one home to another, infection, animal, usually cats, dogs, rodents, and horses. Certain medication also, aspirin, steroids, drugs, antibiotic, beta blocker. Strong emotion, when something makes this child to have to cry too much, fearful, or even laughing excessively, they go into asthmatic attack. Conditions such as GERD and tracheoesophageal fistula, food additives. So be careful to teach the family that be careful of what you add to the food. Usually there's a rule of thumb that any new thing you're going to add to children as a whole, then think about those that are immune suppressed or that have respiratory condition that's easily triggered. The rule is you try it for the first 7 days. Don't use more than one at a time. If you're going to try something new, like a new soap or a new food additive, you can figure out it is this one that is causing the trigger. Of course, foods such as nut milk and other dairy products, endocrine factors for the girls, messes, pregnancy, and even thyroid diseases. Now, for status asthmatica, it is an acute asthmatic attack, and the child displays respiratory distress. despite vigorous treatment measure. This is a medical emergency that can result in respiratory failure and if not treated, of death. The assessment for asthma, you have, most of you have knowledge on this. From dyspnea, wheezing is a classical one. That's why I highlighted after chest tightness, and they start to have, particularly at night or in the early morning when oxygen level or the humidity level has changed. The asthmatic attack will worsen progressively from hiking to irritable breath sounds are coarse and loud with crackles, coarse rhonchi. You hear that from inspiratory to expiratory wheezes. Sometimes you'll be asked to differentiate these two, so take note of them. Diaphoresis and cyanosis. The interventions are usually the priority nursing action we have in acute phase of asthma. Are you okay? But if you just, are you the one that coming in? Hold on, everybody. Let me see who's okay. The person that just came in, can you please mute yourself so that I don't interrupt the class? Babatunji? Marie? Sorry, everybody. Somebody just came in and they are not mute. Okay, prior to nursing action, again, assess airway and respiratory status. You have to administer oxygen, humidify. Quick reference, rescue medication should always be around. Initiate an IV line, prepare the child for chest x-ray if prescribed, prepare to obtain blood sample to determine atrial blood gas. We'll talk about it already. In the event of an acute asthma attack, several interventions are necessary. Hold on. I'm sorry, everybody. Somebody just came in. Can you please mute yourself? Let me see if I can find a person so I can mute them. If I start to mute everyone, it will really be a problem. I'm sorry for interrupting us. Can you, the person that came on and we're hearing you in the back, can you please mute yourself while I'm looking for you? Because there are several persons on the call now. We have 39 persons right now, so I have to really weave on this person. Sorry, everybody. Okay, I found. Okay, I found the person. Sorry.
Good morning.
Okay. All right. Sorry about that. I guess the person is muted now. The medications are in box 39.5 that you can look at for quick reference from short-acting beta-2 agonists, bronchodilators, anticholinergic, and steroids. And in the next box, you find long-term medications to prevent asthma from steroids to anti-allergy medication, non-steroidal anti-inflammatory, and many more are listed out there. There will be time you would need to use a nebulizer, and the nebulizer should have a meter dose regulator that you can use with a spacer. This way you can be able to, for the child not to have, for example, the steroid causing more oral infection. You should also measure the growth patterns, because usually with steroids, it can have an effect on their growth ability. Chest physical therapy, we talk about allergen control and home care measures. Cystic fibrosis. Cystic fibrosis, as you know, is a multi-system auto-recessive, let me fix this sheet, auto-recessive disorder characterized by exocrine gland dysfunction. The issue with cystic fibrosis is that because mucus produced by the exocrine gland is abnormally thick, it obstructs a lot of organ system, from the respiratory to GI to reproductive system. And this is why it's the common symptom will be pancreatic deficiency, and I mean it's a system-wide symptom that have this sweat gland dysfunction, and this is why you even notice that there's some infertility because of the excessive secretions. An increase in sodium and chloride in sweat and saliva form the basis for the diagnostic test. So please remember this. If you ever heard on the test that which condition, or if you want to put it the other way, what is the characteristic test for cystic fibrosis, or the other way around, sweat chloride test is representative of which condition, don't forget it's cystic fibrosis. Keep that in the back of your mind as an added cheat sheet. And if you want to read more on the sweat test, it's in box 37.9. Sorry. I apologize. I switched my thing because of. So it's progressive, and remember, it's incurable. Respiratory failure can be a common cause of death. They may have to do organ transplantation. Organ transplantation may be an option to increase survival rate. And again, the symptoms as the manifestation as systemic can be, and they all run into each other. In this case, with the respiratory system that I talk about, because of the increased production of mucus, it's going to affect respiratory function. Diagnostic tests and interventions that we have to look at. Again, depending on each of the system, you can have different types of intervention. But for the home care, what we have to look at is that involve educating the parents and the child about all aspects of the care. The parent and child, the signs of complication, and that they should take it important to do follow-up. Instruct the parent to ensure that the child receive recommended immunization, because this person has a systemic problem, and they should be immunized so that they can ward off some of these commonly preventable diseases. Annual influenza vaccines are recommended for children 6 months or older, and inform the child and parent about the cystic fibrosis foundation. These conditions require a lot of support. SIDS, sudden infant death syndrome, is unexpected death of an apparently healthy infant. Take note of the age, infant younger than 1 year. For whom an investigation of death and a thorough autopsy failed to show an adequate cause of death. This is a mouthful, but this is how the definition is. Take it just as it is. If you miss a little bit of it, you misunderstand what it says. Again, because it's unknown, there are some factors that have been associated with, high risk condition. For example, they found that there are several theories, but it just came pinned down. It occurs mostly during the winter, during sleep period, not necessarily at night. Affect infants 2 to 3 months of age, higher in boys, higher in Native American, African American, Hispanic. So you can put a lower socioeconomic status group and say that because of that could be a reason. But again, there's a large population that you can isolate that with. Incidence also is found to be lower in people in breastfed infants and those sleeping with pacifier. I mean, of all, to understand that children that sleep with pacifier, according to the research, have lower risk. High risk condition of SIDS include being in the prone position, soft bedding. Obviously, soft bedding is going to have a depression of the child lying in it. Sleeping in a non-infant bed, such as a sofa, overheating, co-sleeping, mothers who smoke or smoke cigarette or abuse substances during pregnancy, and exposure to tobacco smoke after birth. And of course, in the assessment, the child is blue, lifeless, hysternic, frosted blood, tank fluid, and as you can see, diapers may be wet or full of stool. The prevention here is to infant should be placed in a supine position for sleep. I know we all want to put a child on the belly so he can sleep quick, and that could be a risk factor. Mother need to be taught about the risk factor that we just listed. from cigarette smoking to drug abuse to bedding to positioning. Teach the parent to monitor for positional plagial. I'm sorry. Teach the parent to monitor for positional plagial surfeit caused by the supine sleeping position, and the signs for that including flattening posterior, like where the child lies at one side too much. This is why now you start to develop a certain kind of positioning. One of the most important thing I want us to look at here for Sid is that you need to provide some emotional support to the family. They need a great deal of support as they grieve and mourn, especially because the event was so sudden, unexpected, and unexplained. One of your roles as a nurse, as you go, as many of you are, and understand, is that sometimes you have to be the comforter in chief. We're going to talk about foreign body aspiration, because this is, remember when we talk about peace, one of the things we are usually focused on, some of these conditions come in many forms of shift. If you look at some of the questions that you have been answering, even in the NCLEX review, in Sanders and many other test prep, no matter what question you choose, there's something there about safety. So let's take a little break while we watch this video and hope it works. And then we'll come back to describing more about foreign body aspiration. Okay. Sorry. It's joining yet. Okay. Can you all see the video? Anybody? Can one person tell me that they've seen the video starting?
Yes, I see it.
Okay, good, great. Okay. Just a minute. Oh, please don't be slow. I don't know why the video is so.
Hi, are you having fun? Can I have some lunch? I want to go play. How about you eat a couple of grapes and then you can go play? Gee, what's going on? Are you choking? Come here.
Choking can occur when a solid object, such as a piece of food or small object, enters a narrow part of the airway and becomes stuck. Young children are particularly at risk for choking because of the small size of their air passages, inexperience with chewing, and a natural tendency to put objects in their mouths. On inhalation, the object can be drawn tighter into the airway and block air from entering the lungs. A forceful thrust beneath the ribs and up into the diaphragm can compress the air in the chest and pop the object out of the airway. You must be able to recognize the difference between a mild blockage and a severe blockage. With a mild blockage, a person can speak, cough, or gag. This type of blockage is typically cleared by coughing. Encourage someone with a mild blockage to cough forcibly. Stay close and be ready to take action if things worsen. When a severe blockage occurs, a child cannot dislodge the object on her own. Signs of severe obstruction include very little or no air exchange, lack of sound, and the inability to speak or cough forcefully. The child may hold her hands to her throat as she attempts to clear an obstruction naturally. Your help is required to save the child's life. To care for a child who you suspect is choking, begin by asking, "Are you choking?" If the child nods yes or is unable to speak, cough, or cry, act quickly. Stand or kneel behind the child. Reach around and locate the child's navel with your finger. Make a fist and place the thumb side against the abdomen, just above the navel and well below the ribs. Grasp your fist with your other hand. Give a quick inward and upward thrust. Repeat thrusts until the child can breathe normally. Each thrust needs to be given with the intent of expelling the object. If the child becomes unresponsive, gently lower her to the ground. Have someone activate EMS and begin CPR. Look in the mouth for an object after each set of compressions before giving rescue breaths. Remove any object if seen. If you are alone, perform CPR for about 2 minutes before activating EMS yourself. Continue until the child shows obvious signs of life or the provider or EMS personnel take over. Infants who are choking are managed differently than children. Since infants do not speak, it may be more difficult to recognize choking. A sudden onset differentiates it from other breathing emergencies. Signs include weak, ineffective coughs and the lack of sound, even when an infant is clearly attempting to breathe. If you suspect an infant is choking, act quickly. Straddle the infant face down over your forearm with the head lower than the chest. Support the head by holding the jaw. Using the heel of your other hand, give 5 back blows between the shoulder blades. Next, sandwich the infant between your forearms and turn her onto her back with legs and arms straddling your other arm. Place 2 fingers on the breastbone just below the nipple line and give 5 chest thrusts. Repeat back blows and chest thrusts until the infant can breathe normally. If the infant becomes unresponsive, gently place her onto a firm surface. Have someone activate EMS and begin CPR. Look in the mouth for an object after each set of compressions prior to giving rescue breaths. Remove any object if seen. If you are alone, continue CPR for about 2 minutes before activating EMS yourself. For a choking adult, the approach is nearly the same as for children. Stand behind the person, reach around and locate the navel with a finger. Make a fist and place the thumb side against the abdomen, just above the navel and below the ribs. Grasp your fist with your other hand. Give a quick inward and upward thrust. Repeat thrusts until the person can breathe normally. Each thrust needs to be given with the intent of expelling the object. If the person becomes unresponsive, carefully lower her to the ground. If not already done, activate EMS. Begin CPR, starting with compressions. Look in the mouth for an object after each set of compressions before giving rescue breaths. Remove any object if seen. Direct compression of the chest over the breastbone can also create enough pressure to expel an object. When someone is clearly pregnant or obese, use chest thrusts instead of abdominal thrusts. Position yourself directly behind the person. Reach under the armpits and place the thumb side of your fist on the center of the chest. Grasp your fist with your other hand and thrust straight backward. Try to not put pressure on the ribs. If you are alone, try pressing your abdomen quickly against a rigid surface, such as the back of a chair. Abdominal and chest thrusts can cause internal injury. Anyone who's been treated for choking with these maneuvers should be evaluated by EMS or a physician to ensure there were no injuries.
Okay, thank you. We'll go back to our slide. Where we are. Sorry, I have to turn that off. Okay, so I mean, obviously we have gotten all of the thing to know about. One thing I would like to take note of is the education you should always be ready to provide, even the family that don't seem to want to listen sometimes because they're in a hurry to leave, about the parents daycare provider and babysitter education on managing foreign body. So tuberculosis is becoming an issue globally, but even in the U.S., especially we're beginning to have multi-drug resistant strain that occur because of child or family non-compliance with treatment regimen. And a lot of time, the route of transmission is through, of course, inhalation, but most children are infected by a family member or by another individual with whom they have frequent contact, such as a babysitter. One of the things to stand out here, of course, in the assessment for tuberculosis, there are several that you look at, from being asymptomatic to having related to the site of infection, such as the lung, brain, bone. Remember, tuberculosis can be in any part of the body, even though it's usually a respiratory condition. But the signs can show, in this case, a respiratory one as tuberculosis. So you may have signs depending on the system that is being affected. One thing that is done usually to measure exposure is the TST, or what we usually call the PPD. The test produces a positive reaction in the TST, or the Matthews test, as you see in box study 9.8. It produces positive reaction 2 to 3 weeks after the initial infection. And the test determines whether a child has been infected and has developed a sensitivity to the protein Tuberculobacillus. The testing should not be done at the same time as measles immunization. Take note of that, because the viral interference from the measles vaccine may cause a false positive result. Also, sputum tests are done. There are medications. It's 9-month course of INH. Again, some of the pediatric medications are running through these specific diseases. So you have INH. You could also do other treatment with the child, and the parent should be informed. There should be also contact tracing, and to be able to reduce the community infection of this. And in some cases, you may have to use isolation methods. Sputum culture that show a diminished number of organisms and coughing is improving. This includes use of personal filter air purifier N95 or N100 respirator mask. Stress the importance of adequate rest and adequate diet. Case finding, like I talked about, is very important. All right, so we'll move on to the cardiovascular disorder. Because a lot of what we'll be dealing with has to do with defects, so let's watch one more video to give us an insight on congenital heart defects. Let me see first, before we move on, if there's any question. Okay, nobody have a question. Thank you all for being on. I'm gonna put this on. And the reason we're starting this is that even though we're going to start with heart failure and other diseases, but because of the congenital defects that could happen, you could have symptoms ranging from one condition to another. Can you all see this? If one person could just say yes.
Yes, we can see.
Yes.
Yeah, okay, great.
And judgment by a qualified healthcare professional. The information contained in this video should not be used to make a diagnosis or to overrule the advice of a qualified healthcare provider, nor should it be used to provide advice for emergency medical treatment. Common pediatric respiratory problems by Dr. Monica Kleinman. Please note that in this video, we will be following the guidelines used at Boston Children's Hospital. Some of this information may need to be modified based on the equipment, guidelines, and practices in place in your institution.
Hello, my name name is Monica Kleinman. I'm an attending physician in the Medical Surgical Intensive Care Unit at Children's Hospital in Boston. And today I'm going to be talking to you about common respiratory problems that children can present with. Upper airway obstruction. Two of the most common respiratory problems that children can present with are upper and lower airway obstruction. Now, there's a whole set of conditions that can result in upper airway obstruction, but what they all have in common is typically some edema of the soft tissues of the upper airway, either in the subglottic region, below the vocal cords, or in the soft tissues above that, such as the epiglottis or hypopharynx. When you have obstruction in the upper airway, you'll demonstrate increased work of breathing because you're trying to use your muscles to draw in air against a higher resistance than normal. Remembering that the pediatric airway is already fairly small in caliber.
I want to interrupt there, maybe the wrong file I have. So we already talked about the obstruction. I was thinking whether this was the slide, for the respirator. I'm going to leave this in a slide that we can watch, but for now, I'm going to hold on to it. Hold 1 second, please. All right. So we're just going to go back to the slides, and then I'll keep this though for us to use for future. But this was not a congenital heart defect, so I'll just move on. So we're in the cardiovascular system. If you look in box 41, you will see the heart failure, and you will see the left-sided and right-sided about the manifestations they have. I implore you to please take a time, read those, and make some chunking out of the differences so that you know that there are differences between the left and the right. I don't want to go into details of it. They are in the book. They'll be very didactic. But what I want us to actually look at are some of the interventions and the assessment we have to do for nursing. But see if you can get some of the differences between them. And sometimes we can do those in questions and answers. For example, you see jugular vein distension in right-sided heart failure, but you don't see it in left-sided. You see the head bobbing in left-sided. Now, in infants and children, inadequate cardiac output most commonly is caused by congenital heart defect. This is why I wanted to talk about like shunt, obstruction, or combination of both. And this produces excessive volume or pressure load on the myocardium. Now, a combination of left and right-sided heart failure is usually present in infant and children. So sometimes you have both, but it can be discriminated based on tests that will be done. The goal here for treatment is to improve cardiac function, remove the accumulated fluid and sodium, decrease cardiac demand, improve tissue oxygenation, and decrease oxygen consumption. That's a mouthful, but this is what you have to think about when heart conditions are being treated. Assessment of early signs. You have early signs that outline, for example, what it is from tachycardia to tachypnea, scalp diaphoresis, where the child infant especially is sweating, fatigue, and then at that time you have to monitor for the early signs. You have to do respiratory management, monitor the apical heart rate, where you have to count for 1 minute. Remember this, and I noted that in here. When you have to do monitoring for heart condition, especially in children, make sure you count. Epical and meaning that you listen to it and count for 1 minute. Remember that. It's very important. I know hydration very important because of the stress they are going through at the time. There will be time that you will need to, of course, decreasing rest and decreasing environmental stimuli. These things for respiratory and cardio, they run into each other. So I'm going to gloss over some of them to talk about maintaining a neutral environment, unstimulated environment, so that the child can be able to rest, uninterrupted sleep. Intake and output hydration and oxygen is paramount to managing these cardiac and respiratory conditions. There will be time medications that are given where you have to work on the digoxin level and the parenteral instruction, and those are outlined in box 42, where you talk about home care instruction for administering oxygen. Angiotensin, the ACE inhibitors, diuretics, and potassium level. Very important, as many of you know. If you usually the question to you in many and it comes in your exam in many forms and shapes, that the question would be if someone is on diuretic. Let me throw this out. Let me stop here and throw this out to everyone, because these are questions that usually come out that you may not see. You will see all the time, but sometimes you will not think through it. Remember, if you are being asked about questions for someone who is on diuretic, they may not come straight to ask you about certain things, but they will be asking you about diet, about nutrition. So can somebody tell me one diuretic medication that does not affect potassium? Anybody?
Aldactone.
Thank you. So, and the other name for it, easily to understand, is potassium what?
Potassium sparing.
Thank you very much. And who was that?
Babatunde.
Oh, Babatunde, thank you very much. So the reason why you have to remember this is that you understand when we're talking about fluid and electrolyte, if potassium starts to get depleted, there's a lot of symptoms that will cause more problems. So in this case, remember that, of course, you have to instruct the family on CPR when there's heart failure. Now, the parent should be provided with a medication guide for any prescribed medication prescribed for the infant or child. In addition, the nurse needs to review the instruction in the guide and provide an opportunity for a parent to demonstrate medication administration procedure. The reason is when the family is going home and they realize there is something, and they will be on ACE inhibitor, they will be on other medications. Some of them will drop the blood pressure so low the child will look like fainting. Other ones will be like you have to check if you're on digoxin administration, you have to have a parameter of the heart rate, and they need to know this. Otherwise, they're just going to be giving medication on routine. Like, oh, we give it 8 o'clock in the morning when he or she eats, and we'll give it in the evening. Guide them and show the sheet to them, and they have to have a checklist when you're doing that reconciliation. It's very important. Defects with increased pulmonary blood flow, and we're going to have them, in many forms. Intracardial communication along the spectrum or abnormal connection between the great arteries. Blood allows blood to flow from the high pressure left side of the heart to the low pressure left side of the heart. The reason I put this, I will encourage you, in order for you to begin to understand how to make a rationale in your response to your questions in the future, or able to make a decision in your nursing judgment. Sometimes you have to understand the pathophysiology of something. Once you pick that up, that this is how the left side of the heart behaves, this is how the right side of the heart behaves, it's easy for you to pick up what you need to differentiate. Sometimes the NCLEX is usually going to not trick you with so many things. It's going to try for you to understand one of the things that makes this particular disease condition or health condition or medication or diet, what makes this one completely different that you can discriminate and then able to narrow down. So you have to understand these things about how, if there is a connection between two septum of the heart, septi of the heart, and there is a communication between them, what happened to blood flow? you will see as we go through the next set of heart condition about how the blood flow from from terratella or Fowler to everything. Now, the infant typically shows signs and symptoms of heart failure. For the types of, and I listed the type here, ASD, atrial septal defect, atrioventricular canal defect, patent ductus arteriosus, ventricular septal defect. Trust me, all of you have read the Who is this, please? I have to struggle to find this person. I'm sorry. We have a lot of people to verify. Can you please mute yourself, the person that just came on? I have to find it. Okay, all right. Vivian, I'm going to mute you. It looks like you are the one making sound, Vivian. Vivian. Okay. Oh, no, not Vivian. I apologize, Vivian. Somebody else. Did someone just come on? Oh. Okay.
It says
All right.
caller number 10.
Yeah, number 10. I just muted that person. Thank you. All right. Sorry about that. So most of these conditions on your NCLEX or some of the tests you have taken, know that you will see them in one form or shape. So box 43 will give you the signs and symptoms of decreased cardiac output. And as you can see, from decreased peripheral pulses to exercise intolerance, feeding difficulty, hypertension, oliguria, you think, all of these will urinary output, and tachycardia, obviously, that's manifested. Sorry. Sorry, I'm trying to switch back to coming from the screen. Now, the ASD, the infant may be asymptomatic, and you again in box 43, the signs are listed. The defect may be closed during cardiac catheterization or repaired down with bypass, usually before school age. With the atrioventricular canal defect is most common. Take note of that in children that have Down syndrome. One theory could be one of the reasons why the trisomy 21 can have these congenital issues with the heart. The moments is characteristic. Most of the heart, the increased pulmonary blood flow defects tend to have moments. So take note of that as you're reading through them. They are characteristic. It's because of how the blood is flowing through the septum. And so you hear that, those sounds. And if you have the time, go on YouTube and listen to a typical moment sound. It's really important for you to. We'll also encourage you to even go and just Google or go to YouTube and just listen to sounds. For example, how does the sound of crackers? How does it sound? A wheeze, a rhonchi, inspiratory wheezes, expiratory wheezes. Try, I will encourage you, if you have a notepad with you, listen to those sounds. What are the different sounds of the heart, for example? S1, S3, S3, S4, sorry, S1 and S2, we know that. So see, take time to listen to these sounds. They can be very characteristic, and you can make a difference in that. In the management, you have pulmonary artery banding for infants with severe symptoms, that's palliative, or sometimes they have to end up doing a complete repair with bypass. Patent ductus arteriosus is a characteristic machinery-like movement that is present. One other sound you should listen to too, if you're making a note to yourself, is galloping. Take note of galloping. You're going to listen to that one of these days. Again, there's widening pause and bounding pauses that are present, where there's a difference between the pause difference. Management include indomethacin. I know some of you who know indomethacin is a pain medication, but in this case, it's used to manage this condition. VSD It closes spontaneously during the first year of life in children having small or moderate defect. Again, it has murmur. The management, again, is cardiac catheterization or has to be done with bypass. Obstructed defects, blood exiting a portion of the heart meets an area of anatomical narrowing. In this case, it's stenosed, causing obstruction in the flow. Again, the location of narrowing is usually near the valve of the obstructive defect. Usually as blood flow through the valve, that's where the narrow portions are, and that's why usually we hear these sounds about. Again, there may be sign of heart failure, and there are three types here: aortic stenosis, coarctation of aorta, and pulmonary stenosis. Let's look at them individually. Valvular stenosis is the most common type of aortic stenosis, and again, there will be exercise intolerance, chest pain, dizziness when standing for a long period of time. The management will be dilatation, obviously, because of the stenosis. The doctor will want to do a dilatation. Otherwise, there will have to be a surgical procedure, aortic valvotomy. A valve replacement may be required as a second procedure, so usually it may go through a process. Coarctation of the aorta. Now, take note of this. Blood pressure is higher in the upper extremities with children with coarctation of the aorta than in the lower extremities. Bounding pulses in the arm, weak or absent femoral pulses, and lower extremities may be present. So cool lower extremities. So take note of that as it differentiates some of the potential pitfalls that you may want to avoid. The signs of, again, heart failure may be present. You have dizziness, headache, fainting, and then you have epistaxis. And the epistaxis is because, remember, we talk about the blood pressure may be higher. And in this case, the epistaxis will lead to, so you start to have nosebleed from the blood pressure. Management could be balloon angioplasty or surgery. The stenosis, newborns with severe narrowing are cyanotic, and it will also be, management will be including dilatation and surgery. Now, the reason why we should be concerned with this is because you have to begin to look at the post-op nursing management for some of those that have to have surgery done. And this is a defect with decreased pulmonary blood flow. And what we see here is obstructed pulmonary blood and anatomical defects, ASD and VSD that we just talked about. In this case, between the right and left side of the heart are present. Again, remember, going back to the beginning, what I said, you have to appreciate the communication or how the valves work or how the blood flow from one point to the other that comes into the heart from the lungs or from the inferior and superior vena cava. Once you understand how these flow and you find out that there is a communication between them, then sometimes you start to see, or in many cases, depending on the extent of the communication, which means the opening between the two sides of the heart, how much oxygenated or deoxygenation blood is flowing or being lost. The pressure on the right side of the heart increases exceeding pressure on the left side, which allows desaturated blood to shunt right to left, causing desaturation in the left side of the heart and in the systemic circulation. Let me ask a question. So where, if somebody can answer for me, where in the heart, where is the oxygenated blood? Where is the oxygenated blood coming from? Or which part of the heart is receiving the oxygenated blood? Or if you just tell me where it's coming from, maybe that will give us an idea.
From the lungs. The blood is oxygenated from the lungs, then come to the heart, go to the aortic, then go to the systemic. Venous return comes with deoxygenated, goes to the pulmonary, then go to the lungs and become oxygenated.
Oh, wow. You just summarized a whole cardiac anatomy. So I don't even want to ask. Just clarify for me, what kind of vessel is bringing this oxygenated to the heart? What's the name of it? I mean, not just tell me the type. Just give me the type. You don't have to yours. A what?
In the aortic, they are the arteries.
Which artery?
Pulmonary.
Yes. Remember
From
that.
The heart is pulmonary.
Is the only artery in this case.
That carries oxygenated blood.
Yes, ma'am. All right. So now typically hypoxemia, thank you very much. What's your name again?
Mariama. Mariama Kane.
Thank you very much. Thank you very much. Typically, hypoxia and cyanosis appear, and here are the types: teratology of Fallot and tricuspid atresia. Now, in the teratology of Fallot, it comes with 4 defects. Remember these conditions, you're going to see them no matter what test you take. You're going to see them somehow, especially if you start to take a lot more of the questions. VSD, pulmonary stenosis. Now the next thing you start to see is that there's an overriding aorta. The reason why your colleague was answering this, your fellow classmate, was to understand how this blood flows. Now, once you start to override the aorta, something going to be happening, not so good. Right ventricular hypertrophy. As a hypertrophy, it becomes difficult. The muscles become to be under stress, and then you start to see acute episodes of cyanosis. Children with increasing cyanosis, they will be squatting, and you start to have clubbing of the fingers and poor growth. So this is why usually in these cardiac conditions, they start to examine as much as even the finger to understand. But the squatting is very characteristic because they want to make up to be able to breathe, and it's not working. Management, palliative, shunt, or complete repair. The tricuspid atresia in this case is missing, and in such situation where there's no way for the tricuspid to have existed, now there's complete mixing of oxygenated and deoxygenated blood. So instead of the oxygenated blood in the left side of the heart, resulting in the systemic desaturation, pulmonary obstruction, and decrease. And so there's a cascade of problem because the oxygenated and oxygenated blood are being mixed. And now the child has to be able to, how do you get this systemic oxygenation? This is what leads to cyanosis. And the heart is pumping as a feedback, negative feedback, to be able to seek for more oxygen, or to kind of have you send as much oxygen like they have, whatever is remaining within the system, to go up, either to the brain or to the toes or everywhere in between, especially to the vital organs. So dyspnea in newborn, chronic hypoxia and clubbing in older children. And the management, if it's ASD, if it's small, the defect may be closed through cardiac catheterization. Otherwise, they have to have surgery done. And let's look at it when these defects are mixed. Fully saturated systemic blood flow mixes with the desaturated oxygen, again causing desaturation of the entire systemic blood flow, pulmonary congestion, decrease in the cardiac output. Of course, there will be sign of heart failure. It depends on the degree. So these are the types that we could look at: hypoplastic left heart syndrome, transposition of the great arteries or transposition of the great vessels, total anomalous, pulmonary venous connection, truncus arteriosus. These are not conditions that you're going to see more often in your exam, but it's good to recognize them as they are mixed condition, they are mixed defect that can have multiple symptoms running each other. So in this case, for the intervention, you have to monitor for signs of defect in the child, the infant or child, vital sign, respiratory status, the nasal flaring, crackles, rhonchi, and wheezes. Again, remember to find these sounds in YouTube. Make sure you watch the video and you listen to them instead of just reading about them. They are very important. Respiratory effort is increased. Place the child in reverse Trendelenburg to help elevating the head and upper body to decrease work on the breathing. Again, we talk about the oxygenation, and the trachea tube may be prescribed, and it has to be usually available with ventilator and monitor for. So in our priority nursing action for hypercyanotic spell occurring in an infant, place the infant in a knee chest position, administer 100% oxygen. If you feel usually there will not be a way to administer oxygen, you may have to use mask. Administer morphine sulfate, administer fluid intravenously, document occurrence action taken in the infant. A lot of times, some of these cardiac conditions, there are protocols that are already set in place about what to do, doing, for example, a cold, or doing setting respiratory emergencies. So you will not be going against everything. This is why you should usually know your your nursing procedure, nursing management, facility rules. Some of these things you have to do them and be ready to do that. Intervention and teaching. Priority nursing action we talk about. You have to look at vital signs, weight monitoring. Very important to monitor weight. When you start to have, depending on the order that is given, as to how much weight the child should gain, or if they gain beyond that, you have to report it or send a message to the doctor. So this is why you have to do daily weight. Nutrition, we emphasize rest. It's very important. And the procedures that are done, and they are all outlined in box 44. Home care after cardiac surgery. Rheumatic fever is an autoimmune condition that affects the connective tissue, joint, skin, blood vessel, and central nervous system. Is the most, hold on, let me make sure there's no question here. Okay, thank you, Lynette. Everybody's eager to have you on. The instructor is on. The most serious complication is rheumatic heart disease, which affects the cardiac valve, particularly in the mitral valve. Jones criteria are used to determine the diagnosis. The reason I will encourage you to look at the Jones criteria. Some of these things give you a guide. Usually in many assessments we're going to be doing nowadays, we have so much tools to help us. They also are algorithms to guide you. So read them. It's not going to be something that you will see very often, but the criteria here has to look at major criteria: carditis, atragia, chorea. These are different manifestations. And then the minor ones are fever, atragia, elevated ESR, prolonged TR interval on the EKG. Those could give you some guide. And the assessment will be, you can see the assessment in figure 41, where it was look at the chorea in this involuntary movement or extremities, face, and affect speech. Fever, carditis, abdominal pain, nodules, and polyarthritis. When you start to see them, usually they are conditions to look for, to be able to do an assessment for rheumatic fever. A lot of time with rheumatic fever, there are going to be some diagnostic tests that is going to help you, but because it's a serious condition, if it becomes a complication, it can lead to rheumatic heart disease, which affects the valve, particularly the mitral valve. The intervention, again, is about vital signs, making sure that you control pain and inflammation is in rest, limitation of exercise, administer salicylics and anti-inflammatory as prescribed. Just make sure anytime you're administering salicylic and anti-inflammatory, make sure the child doesn't have other conditions that will preclude those medications that we'll talk about later. Seizure precaution, and of course, advise the child to inform the parents if anyone in school develop a streptococcal throat infection. In rheumatic fever, something to note here, assessment of a child with suspected rheumatic fever includes acquiring about a recent sore throat, because the rheumatic fever manifests 2 to 6 weeks after an untreated or partially treated group A beta hemolytic streptococcal infection of the upper respiratory tract. So this is why I usually kind of ask the question if you start to have this kind of funny fever or unusual cardiac manifestation, say, have you had sore throat recently? Kawasaki disease, also known as monocutaneous lymph node syndrome, is an acute systemic inflammation. Again, the cause is unknown, but it's associated with an infection, an organism or toxin. Cardiac involvement is the most complicated. Aneurysm can develop, and as you know, if there's aneurysm, especially depending on the size of the vessel, if you have aortic aneurysm, you could have a serious problem with blood flow because it will be compromised. Assessment depends on the stage. You have the acute stage where you have from conjunctival redness to red throat and swollen hands and rash, to the acute stage where you have crackling lips and fissures. to skin desquamation or joint pain and thrombosis, and the convalescent stage as well, where the child appears to be normal, but the signs of inflammation may be present. In the intervention, we have to assess the extremities for edema, just as you would do in the assessment of everything you found in there. Examine the eyes for conjunctivitis, mucous membrane, administer soft food and liquid that are neither hot nor cool. Wait daily. Again, we have to emphasize this in cardiac condition. In fact, in many facilities now, once someone has a cardiac disease, usually they put them on cardiac monitoring. And one of the things is to do weight and fluid restriction. You could administer acetylsalicylic acid. I'm sorry. Yeah, acetylsalicylic acid as order for a fever, and anticoagulant. It will be time that immunoglobulin will have to be administered intravenously. And of course, if you look in box 46, they have parental education about what to do. So let's move on to the, all right, we're doing good. We're going about an hour and a half on the glomerulonephritis, gonorrhea condition. This is a group of disorder. So as anytime you think about it, just assume that there's a cascade of problems that could happen if someone develops glomerulonephritis. And again, think about the anatomy of what happened in the glomerulus and the nephron from the entire system of the filtration. So when there is a problem with inflammation and there's constriction and fluid is not flowing well, enzyme, there have been changes from the enzyme to the chemical balances and the fluid and electrolyte balances, the kidneys start to lose function. The causes could be from immunological diseases, autoimmune, antecedent history of pharyngitis or tonsillitis 2 to 3 weeks before. It may be acute or chronic. The kidney could shut down acutely, and in that case, it becomes an emergency. But even in the case of chronic, that could lead to conditions that could lead to the need for dialysis. So in any way, we have to manage them and recognize their differences. Complications could be from kidney failure, hypertensive encephalopathy, pulmonary edema, and heart failure. The assessment, periorbital and facial edema, you have urine, decrease in urine output. Let me give us, as you all know, on the sidebar, 90% of the reason why that people have high blood pressure is considered, can anybody give majority of the blood pressure that patients have is considered what type of hypertension? Can anybody tell? Most of the high blood pressure that develops are referred to as what? Or is referred to as what? Anyone? Anything? Last call? Anybody heard of essential hypertension? Anybody? Am I on?
Yes.
Okay. Okay, good. I thought I was speaking to myself. So you heard about essential hypertension, right? Do you have any of you figure out what does that word mean? It means you cannot tell what it is, the exact cause of it. And about 90% of every high blood pressure is related to it's unknown. Yeah, you can say, oh, because the person is obese, because it is that, but you still can't track. But the remaining minute one, the small percentage, are related to certain condition. And one of the major one is kidney problem. Have you ever heard about the renin-angiotensin system? Any of you?
Yes.
Okay, good. So in this case, the reason I want to draw your attention to glomerular or kidney problem that will lead to hypertension. In this case, this hypertension, these are the ones that are very difficult to treat. Just the reason I'm fanning around it is for you to understand, because you cannot give them amlodipine. The doctor will not give them just amlodipine, propranolol, or every slew of medicine that exists without treating the kidney problem. You understand it? So if you cannot identify the organic problem of this particular hypertension, and because of the renin-angiotensin system that has an effect on blood pressure control, this is where it's coming from. So take note of that, because kidney problem, especially these acute and chronic kidney problem, could lead to hypertension, and it can be pathological, really difficult to control. Proteinuria, which is usually a classical sign, and it will be the urine will foam. Exothermia, where you have the blood urea, nitrogen, all the chemicals flowing high, and they start to have all these sometimes skin manifestation, and they have anti-streptoline theta. It's diagnosed disorder caused by streptococcal infection. The intervention, if you go out to our priority nursing box, will be to fluid volume overload in child with glomerulonephritis, assess the airway, vital signs, weight. Again, we're talking about weight over and over. Increased pulse, we have to assess for bounding, assess for distended hand and neck vein, assess for elevated CVP and dysrhythmia. CVP is central venous pressure. Notify the healthcare provider and carry out prescription, including water and sodium restriction, and administration of diuretic. You have to do teaching to the family and even the child. Sometimes children can learn a lot more as well. So sometimes telling them, teaching them can go a long way to help us to make them part of the team. Nephrotic syndrome. So everything I've said about the glomerulonephritis or the kidney kind of will run into these other ones as well. So it's massive proteinuria in nephrotic syndrome. And you will see that in box 41, figure 41.1. As you can see, from explaining to you how well the pathophysiology goes from renal glomerular damage to proteinuria, massive to hyperproteinuria, and going down to edema and hyperlipidemia. The primary objective here of management are to reduce the excretion of urinary protein. Remember, you have to figure out if protein is being lost from one part of the body, how you have to either replace it or stop the progression of that disease, because proteins have high molecule. They are not supposed to be seeping through the glomerular, the whole nephron system. So emitting protein-free urine, reduce edema, prevent infection, and minimize complication. Now, in the assessment, the classical manifestation of nephrotic syndrome are massive proteinuria, hypoalbuminemia, and edema. Obviously, one wrong. If you're losing too much protein, the albumin is going to drop. The intervention intake and output, weight, edema, nutrition, corticosteroids. You may have to use immunosuppressant therapy, diuretic, plasma expander, and parenteral instruction. Hemolytic uremic syndrome, and then this is associated with bacterial toxin. It's good to know these for as you read to be able to differentiate some of the condition. You're not going to usually see them as often, but understand that in this case there may be blood. Clinical features include acquired hemolytic anemia, thrombocytopenia, kidney injury, and the assessments is a triad that you have to look at where there's anemia, thrombocytopenia, and kidney failure. And you can see that in box 42.2 from vomiting, irritability, lethargy, marked pallor, oliguria, or even anuria and central nervous system involvement. And the intervention include hemodialysis. Now you see where this is going, peritoneal dialysis with anuria and fluid balance, infection prevention, nutrition, medication, and blood product. Enuresis, this is when the child is unable to control bladder. And we know the reason we have to talk about this, a lot of time, there will be time that where you have to do some parental education, and this is not uncommon to find out that children are wetting the bed, and even at older ages. So we need to work in there. By age 5, most children should be aware of their bladder food and be able to control, but they can in this case. So it may be the types would be primary nocturnal or secondary acquired. You have to assess for bedwetting with no extended period of dryness. The intervention could be from urinalysis, whether it's infection, and it has to be culture, family support, limit fluid at night, depending on when the child goes to bed, avoiding before going to bed, and also have the child participate in the care and do some reward system. If they didn't have a, some of these things, if we as parents could practice it, you'll be surprised that it could make our life easier. Behavioral conditioning, medication, and follow-up. Cryptorchidism, this is when one or both testicles fail to descend to the inguinal canal. I've seen this many times into this scrotal site, and in this case, you have to palpate to make sure if the testicles are not palpable, you know that it's not, it didn't descend, or it's just absent. Sometimes there are times that they have found that the testicle did not descend. Monitor during the first 12 months of life to determine whether spontaneous descent will occur. At the age of 1, medical or surgical intervention may be instituted. There may be HCG medication given. A surgical correction may be done. And in this case, if it's done, you have to monitor for bleeding and infection. Parental counseling has to be done because, obviously, a parent wants to have a child that is complete. And now, in this case, there's no testicle being palpated. Epistadia and hyposphadia, these are two conditions that lead to deformity of the tissue of the urethral positioning if you look at figure 41.2, you will find out that the epispadia is a condition in which the urethra opens at the dorsal, at the top of the penis, and the hyposphadia meaning is below the gland penis. The reason to be concerned about this is because it could be sources of infection, and you want to make sure that it's clean and eventually it's closed. Circumcision may be performed because the gland penis has a different position, but it has to be careful. On a newborn with episphadia or hyposphadia, may not be performed because, again, considering that there could be source of infection. Although there are other surgical techniques used to repair these defects, the pediatrician may prefer using a full skin for surgical reconstruction. So that's the rationale. Surgery, post-op care, you have to do. Bladder extrophy, congenital anomaly characterized by extrusion of the urinary bladder. In this case, it's outside of the body. The bladder is out, or defect in the lower abdomen. To be concerned, it requires surgical management. What you have to look at in this case in your assessment and intervention is the exposed bladder mucosa. You don't want that to be dry and also to be infected. There will also be widening symphysis pubis, where the child just like more losing up, defects of the external genitalia, and we have to monitor output, UTI, or wound infection, integrity of the exposed mucosa, prevent the bladder tissue from drying, antibiotic, and emotional support. This is very traumatizing to family to see a bladder out. Now, a note here is applying petroleum jelly to the bladder mucosa is avoided because it tends to dry out, adhere to the bladder mucosa, and damage the delicate tissue when the dressing is removed. All right. Do we want to go for one more chapter and then we can have Stanton to come in with announcements?
Yes.
Okay. Yeah, we are almost there. After this, we really wanted to hit the respiratory much more because they flow into each other. So this wouldn't be much to hold us. Okay, so cerebral palsy, as the instructor had written some of the highlights to look at in the neurological system, one of them will be to look at cerebral palsy because we're gonna see that a lot. Now, it's characterized by impaired movement and posture resulting from an abnormality in the extrapyramidal and pyramidal motor system. Again, understand that so that once you pick that up, that this is going to be that a person cannot hold a certain positioning, then you can start to see what is happening. The most common clinical type is spastic, and it represents an upper motor neuron type of muscle weakness. The less common one is atasic, and mixed. So most time we tend to believe that the atasic one is usually going to be the one we see because of the movement and shaking, like someone who have Parkinson. But that's usually they are much more. You get more worried about the one that's going to be spastic because that can lead to much more muscle weakness. You have to assess for extreme irritability and crying, feeding difficulty, motor performance. Once you start, as the children grow, they have different signs from the monotonic reflex to, primitive reflexes that are supposed to disappear or that are supposed to be coming on, or how much they grasp well. Once you see these signs are now showing up and you start to see some stiffness and rigidity, you know that something is not right. And that's where the assessment cascade starts. In figure 42.1, if you look there, you will see the different positioning. Abnormal posturing, the decorticate, where is the flexion position of the child, and the arm, the decelerate extension posturing. So if you have a time look on the picture, it will give you a little more vivid way to understand how well the arm is going to be. One thing we want you to look at is that you should start to watch out for seizure. Seizure may occur in this case, and the child needs to be assessed for that. Now, the intervention, the goal is for early recognition and intervention to maximize the child's ability. Because as children with cerebral palsy, as they go for a long time, that they don't get management, they start to have other collateral issues. They could fall, and that could lead to more problems. They will not learn quicker. They will not have some. They will have some stiffness, and then it will be difficult to have to go through physical and occupational therapy to be able to realign some of their body, especially their hands. So this is why it's good for early recognition, and they can, from what we have seen, they do live comfortable and community life. Interprofessional team approach is implemented to meet the many needs of the child. Like what I just talked about, from physical therapy, occupational, to speech, to everything in between. Education and recreation, they do usually are part of special ed program. They do, I know several of them in the community that take part in recreation. They usually sometimes they have their own tournaments, and it's very fun. Assess the child developmental level and intelligence. Again, early recognition can actually wall off some of the deficits that we have. As you know, there are parameters in child growth that we dealt with earlier, depending on the stage of life, the first 5 minutes, the first 100 days, the first 5 years. If you miss a growth pattern, if you miss one of those milestones, you have a lot of issues. So you want to make sure this is recognized early. So as you take care of children, pediatric, and you see newborn, and you start to notice an abnormal changes in their condition, try to alert the team. Encourage early intervention and participation in school program. They need to be the social part is very important. Social interaction. Prepare for using mobilizing devices to help prevent or reduce deformity. Encourage communication and interaction with the child on his or her own developmental level. Don't expect all of them. And these children can take part rather than their chronological age. Remember, some of these children, I know a lot of them. I have a wonderful one that we have interacted for more than 20 years, or actually maybe like 18 years about. But she still looks young. So when you have to deal with her, you have to assume that she's 5 years or 10 years. So here you are going to be interacting with this child on his or her developmental level. And usually there are psychologists, social workers that are able to work with them. And you as a nurse, since you most time can do an umbrella intervention, you will recognize what to do at the time. Provide a safe environment by removing sharp objects, protecting helmets, to prevent fall, seizure precautions, save appropriate toys, position in upright. We talk about upright position, especially with during and after meal. I will add here. Medication may be prescribed to relieve spasm, which cause intense pain, because anti-seizure medication also sometimes they are uncomfortable. You need to find a way to relieve their discomfort. Provide parents with information about the disorder and treatment plan. Encourage support groups for the parents. Usually, most of the parents that I know of children with these congenital neurological or generally congenital issue, once they are part of a support group, they get to realize that it becomes routine and they can support other family members. So it's really, really important. And it's not unusual for you, the nurse, to also sometimes have a child like that have issue. And when you go in with a professional and parental experiences, it can be even an added experience. So if you ever have the time, you want to volunteer in some of these activities in your life, these are support groups to be a part of. You go there with a professional introspect, which can be very, very good as well. Head injury is another topic we should take keenly. If you look in the book, figure 42.2, you can see how much of an object being cracked on a child's head. Pathological resulting in any mechanical force to the skull, scalp, meninges, or brain. And it will be manifested depending on the type of injury and subsequent amount of increased intracranial pressure. If it's open head injury, you can get away with it as compared to closed head, which is more serious because the vault is closed. In the case of closed head injury, there have been times even in closed head injuries, sometimes some treatment has to be that they have to open the skull up to reduce the pressure. Sometimes it can be as simple as that. I mean, I don't want to take it kindly as simple, but once it can reduce the pressure, that can usually relieve some of the problem, and then they can have other type of medication that reduce the edema and possibly if there's any bleeding. This type of injury can also be caused by shaking baby syndrome. So take note of that. Sometimes people play with babies and move them, and the thing is fun. Be careful. I know we nurses, when we tell the family not to shake the baby and set him on, sometimes they feel that you're trying to be too careful, but it's important. Sometimes you have to tell them some of these conditions that can happen. Now, a note here is the child's level of consciousness provides the earliest indication of an improvement or deterioration in neurological condition. So level of consciousness very good. As much as children can sleep for many hours, but there's a way you can awaken them, and there's a way you can tell their level of consciousness. They may not talk, but there are signs you can use. And so in the assessment, you look at early signs as they are listed here, from irritability to high pitch in infants, bulging fontanelle, and the child with headache, nausea, vomiting, diplopia. This is one thing you should always note. Usually when I'm doing community teaching, one of the things I stand out, because people can easily catch that. Anytime there's a hair injury and the person says, I can see you too, like I can see you alone, or I see an object too, I say rush them to the hospital. This is going to be an emergency because there is bleeding going on. There's something going on in the brain that is much more worse than if you were too long. So, but I mean, back to the infant, you have Massey-Winn sign where like crackpot sound or pump percussion of the head. Some of these sounds, again, listen to them. It will be very helpful. And then the setting sun sign where the sclera visible above the iris. It's like the sun is setting. Those are some new ones to understand about some of these signs. Now with the late sign, obviously the level of consciousness, bradycardia, all of them start to occur, low, decrease level of consciousness. The positioning we talk about in figure 42.3, decorticate, flexion posturing, and decelerate, extension posturing. Start to see that. Shin-stroke respiration, and coma. These are serious conditions that require. Now, in hair injury, a note here is immobilize the neck and spine after a hair injury if a cervical or other spinal injury is suspected. When the spinal cord injury is ruled out, elevate the head of the bed Then 15 to 30 degree, if not contraindicated and as prescribed, to facilitate venous drainage. Remember, one of the things that stand out with the lay person out in the community, when someone have a fall, the first thing they want to pick them out, they want to move them. If you are around, one of the first things, especially when it's hair injury, this is why one of your set of your assessment that you're ever going to be doing is to usually ask if someone had a fall. One of the questions is, did you fall on your head? If a child or anyone fell on the head, you start to institute measures to be able to keep them in an alignment. Very important. Monitor the airway, assess for injury, positioning. We have mentioned that vital signs and level of consciousness. And you have to report increase in intracranial pressure. There are signs to indicate those. Keep stimuli to a minimum, attempt to minimize crying in a child. If you have to move the child or have to, kind of play some music for them, find what is more comfortable. Withhold sedation medication during the acute phase of injury so that the changes in level of consciousness can be assessed. This is usually going to be part of your protocol to understand, and don't be too quick to give medicine for this child, right? It could cause more problem. Of course, you initiate seizure precaution. Monitor response to pain, IV fluid. We have to do MPO, assess for wound. The wound, that if it was open head injury, you can be sure to be careful with that wound. There are usually special dressings that are done to be able to make sure that you don't have communication between the outside and inside, especially so that you don't have issue with infection flowing. Administer tepid sponge bath, avoid suctioning. Remember, you know about suctioning. One of the issue of suctioning is that you increase pressure. Even with the few seconds that you have to hold and you have to, rotate, those can increase pressure. As prescribed, administer, Tylenol for acetaminophen, do the generic for headache, anticonvulsant for seizure, antibiotic. Steroids or osmodiuretic may be prescribed to reduce cerebral edema. Most time, you will see a prescription for osmotic diuretic so that it can reduce the pressure while at the same time not creating too much issue with immune suppressant or accumulating other fluid. The steroids will help to reduce the corticosteroid, will help to reduce the inflammation. A lot of times these are monitored over time. With children, they usually show signs depending on the extent of the injury of reduction depending on the extent of the injury. In box 42.2, you'll see signs of brainstem involvement. In this case, when the brainstem is involved, you start to see sluggish, dilated or inchoate pupil, widening fluctuation, or notable slowing in the pulse, deep, rapid, and intermittent gaps in respiration. Now, drainage from the nose or ear needs to be tested for the presence of glucose. Drainage that is positive for glucose, as tested with reagent strips, indicates leakage of cerebrospinal fluid. Healthcare provider must be notified immediately if the drainage tests positive for glucose. Hydrocephalus is an abnormal imbalance in the cerebrospinal fluid, absorption or production, and it could be caused by malformation, tumor, hemorrhage, infection, or trauma. It does result in head enlargement and increased pressure. There are two types, communicating and non-communicating. In infant, there are several signs, as you can see out there. One of the signs is setting sun eyes that we talked about earlier, but also the fontanelle will be tense, bulging. In the case of the child, behavioral changes such as irritability, ataxia, and nystagmus, where the eyes start to move irregularly, and the late signs will be high, shrill cry, and seizure. Treatment, surgical intervention could be ventriculoperitoneal shunt, where they put, if you see the photo in your book in figure 42.4, you will see that they put a shunt in and bring it down to the stomach area so that it drains. Or as the child grows, they have to change that shunt to lengthen it. Ventricular atrial shunt as well. The shunt revision may be necessary as a child grows. Like I said, you have to look at the perioperative and pre and post operative intervention. Again, we already mentioned about a high, shrill cry. This is very characteristic to remember in your test of increased intracranial pressure. Meningitis is an infectious process, could be bacteria or virus. The way to test the bacteria has to do lumbar puncture. Viral meningitis is usually associated with conditions such as mumps, paramyxovirus, herpes virus, and enteroviruses. The assessment again depends on the type, age, and preceding illness, but you could it could be from fever, chills, headache, vomiting, diarrhea, and poor feeding or anorexia. Let me just look here to see if we don't have any. Okay, that's a couple of questions. Yep. Thank you, Lynette. Let me fix this. Oops, I'm sorry. Okay, take some notes as you see in the comments that are being written out there. Some of the things to look at, or we have the notes to look at. Respiratory, meningitis intervention, respiratory isolation, precaution, administer antibiotic and antipyretic, neurological assessment. We will be monitoring a lot more for the level of consciousness, whether irritable, and we already talked about nutrition and RNO. But one of the things you have to look at is that if there are signs of petechiae or rash, whether this could indicate some bleeding or thromboemboli. Also, you can look at hearing loss. See if those that may have had contact with this child need to be treated or tested, because meningitis, as you know, when you in from daycare to schools, a lot of contact can spread easily, and pneumococcal conjugate vaccines is available. Submersion injury, this is when survival of at least 24 hours after submersion in a fluid medium. What you look at here is that there will be hypoxia, asphyxia, depending on the extent, the time. If the cerebral cells sustain irreversible damage after 4 to 6 minutes of submersion, this is where you talk about drowning could occur. Outcome is predicted based on the length of submersion in non-icy water. A child who was submerged for more than 10 minutes and does not respond to CPR support measures within 25 minutes has an extremely poor prognosis. The intervention is monitor ventilatory, circulatory support, respiratory status, aspiration, pneumonia, and parental teaching. Of course, every parent has to be taught about this. Be careful with children around pool, around even bucket. They can drown themselves in literally anything. So it's very important to keep note of that. Okay, Reye syndrome. Let's take note of this, because as we're talking about at one point with certain medications, salicylic medication, you have to be careful to measure to make sure that any of the children is giving, this could be something to be careful of. History of systemic viral illness. I was moving my screen. 4 to 7 days before the onset of symptoms. They could have auto liver function and lethargic, progressive neurological deterioration, increased blood immunity level. You have to take rest, monitor for bleeding, and impair coagulation. Okay. What is this thing doing? Okay. Seizure disorder, excessive and unorganized neurological changes. They are classified based on whether they are generalized, partial, unclassified, or depending on the area of the brain involved. The types could be, again, seizure including tonic-clonic absence, myoclonic, and atonic. Good to know these, because seizure will come in different forms and shift. shape rather. Partial seizure arise from specific areas in the brain and cause limited symptoms. Can't get this to stop. Now, in the assessment, that should be what we should be concentrating on a lot more. Intervention, obtain information about the parent about the onset of the problem and what precipitated and behavior before and after seizure. Determine the child history related to seizure. Sometimes if you get to realize that the seizure disorder they are having as much as they may have other condition, but for example, if they have epilepsy, you know that it's a long-term problem and you can handle that in a different way. But if the seizure has to do with certain kind of chemical issue at the time, then you have to handle that. Sometimes poison could lead to this, and you never know. Determine ask the child about the presence of oral, like warning signs, and warning signs are usually those, for example, in epilepsy. Monitor for apnea and cyanosis. Post-seizure, the child is disoriented and sleepy, and you can see again, over and over, we'll be talking about seizure precautions. Always good to remember in those diseases. I can't get this thing. See, intervention, the intervention with seizure disorder inbox 42-3, including ensure airway patency, suction equipment, time the seizure episode. If the child was standing or sitting, ease the child down to the floor and place the child in a sideline position. Pillow, use of pillow, loosening restrictive clothing, remove eyeglasses from the child if present. Allow seizure to proceed and end without interference. If vomiting occurs, turn the child on one side as a unit. Do not restrain the child. Place anything in the mouth. Those of you who have been practicing nursing or being around healthcare for many years, those days they will put thumb blade powder in the mouth, so you're not supposed to do that anymore. Nothing. Do not restrain, place anything in the child's mouth or give any food or fluid to the child. Prepare to administer medication. Remain with the child until the child recovers fully. Observe for incontinence, which may have occurred, and then care for that. Especially older children will begin to feel a little more ashamed, for what happened. So you have to help to support them. Neurotube defects. These are central nervous system defects result from failure of the tube to close. This is why, if there's one thing you have to remember about neurotube defects, always remember folic acid. It's recommended during pregnancy. It has been shown that low folic acid or the lack thereof can precipitate neurotube defect. So remember that, put that in your cheat sheet. Reduce it. So folic acid is recommended in pregnancy, during pregnancy, to reduce the occurrence of these conditions. The associated defects include sensory motor disturbances, dislocated hips, talus equinovarus, clubfoot, and we'll talk about those, hydrocephalus. The defect closure is performed soon after birth, and they include spina bifida occulta, spina bifida septica, meningocele, meningocele. I'm sorry. So in the assessment, the neurotube assessment intervention, we can do those in details in the book. ADHD, behavioral disorder characterized by developmentally, this thing can't work for me, inappropriate degree of inattention and overactivity and impulsivity. Very important when we're talking about some of these neurological conditions to do early diagnosis. This can prevent impaired emotional and psychological development. Diagnosis is established on the basis of self-report, parents and teacher report, and use of assessment tools. In the assessment, the fidgets with hand and feet or squirm in the seat. They are easily distracted, so you can look at attention span is poor. They shift from one uncompleted activity to another. They can stop talking. They interrupt or intrude to everyone or everything, and they engage in some dangerous activities without considering the consequences. Interventions will include behavioral therapy, medication, maintaining a consistent environment and appropriate classroom placement. Promote self-esteem, stimulant medication. A lot of them are on medication. And then follow-up care. Very important, because if the family start to feel that this child is doing better, and then there's a lot of assumption that medications are sometimes precipitating these problems, so we stop this medicine, and then everything starts all over, and there's a cascade of starting again, and then the child takes time to be able to recover and to be calmer. So please encourage in the follow-up that they should definitely make sure they take the medication and come back for assessment every now and then. Autism spectrum disorder, this is a group of, it's a complex. So look at it that there are multiple conditions, disorder of unknown causes, composed of qualitative alteration in social interaction, repetitive impairment with repetitive, restricted, and stereotypical behavior pattern. The impairment can range from mild to severe: autism, Asperger's syndrome, Rett syndrome. There will be intellectual and social behavioral deficit. And in the assessment, we have to look at social, communication, and behavioral aspects. For the intervention, determine the child's routine habits and preferences and maintain consistency as much as possible. Work with the ways of communication, meaning how the child wants to communicate. You also have to understand here there could be, if there will be some developmental issue, you have to handle other conditions that may be associated with that. But safety is very important. We have emphasized that over and over in pediatrics, and you may have to refer this to special program. Autism require special program to manage them. Even if you feel that they are at a low, moderate level at this time, better to seek professional treatment or management, from social to other interdisciplinary. Provide support to parent. Ensuring a safe environment for a child with autism is a priority. Intellectual disability. This child manifests sub-average intellectual functioning. Down syndrome is a congenital condition that results in a moderate to severe disability, of course, as associated with trisomy 21 chromosome. The assessment here is to check for cognitive skills and level of adaptive functioning. Once the assessment is able to come up with this level of diagnosis, you can be able to develop, for example, a nursing diagnosis, interdisciplinary diagnosis about how this child should be considered in terms of their cognitive level. There will be delay in fine and gross motor skills, speech delay, decrease in spontaneous activity. They usually will not be able to take on certain initiative, and you have to be helped. But over time, studies have proven that they can be able to do a lot, that are optimal for their condition at the time. They are even able to function in school with certain help. They may be irritable, poor eye contact during feeding. The interventions, again, I've been adding some through the assessment. Medical strategies are focused on correcting structural deformities and treating associated behavior. Again, you talk about you want them to be skillful, you want them to play, be safe, work with family about care, and provide information again regarding support group and community agencies. They usually take part in a lot of community activities so that they get to know that there are other people like them, and also they could be doing much better and can be a support to another person. All right, do we want to take a break before we finish the last topic? Or any question? Comment? So after this, we'll do the infection. Those are shorter topics. And then the medication. Any question? We want to take a 10 minutes break while I get Stanton to talk to us?
Yes.
Okay. All right, thank you. Let me see, I see some comments here. Okay. All right. So let's talk in 10 minutes, and it's about 12:20, 12:24. So we'll be back 12:34, 12:35. Thank you.
This conference will now be recorded.
In our second, after the break, we're dealing with musculoskeletal disorder for chapter 43. We started with developmental dysplasia of the hip, and the PowerPoint will be provided. In the dysplasia, we talk about the head of the femur is seated improperly in the acetabular cycle or pelvis, and the degree of the developmental dysplasia of the hip. And we listed 3: acetabular dysplasia, subluxation, dislocation. Assessment would be depending on the age group: neonate, infant, older infant, and child. The interventions are outlined here, considering the age: birth to 6 months, 6 to 18 months, older child, and of course to do parental instruction. Congenital club foot require management to be able to the goal of treatment is to achieve painless plantar so that the child will be able to walk on the sole of the foot with the heel on the ground. Long-term intervention follow-up is needed, and we have to assess for the deformity as outlined in figure 43.3. Treatment begins as soon as after birth as possible and require manipulation and casting to be performed as the child grows. Because of the rapid growth, this child may have to have this cast manipulation and casting done weekly. Surgical intervention may be necessary if the normal alignment is not achieved by 6 to 12 weeks, and we have to monitor for pain and monitor neurovascular status. Again, we are supposed to contact the healthcare provider immediately if there is a sign of any neuromuscular impairment, as noted with the child in cast. Idiopathic scoliosis. Here we have to look at some structural issues, especially with self-esteem. And the idiopathic scoliosis usually is diagnosed during the pre-adolescent spurt. Screening are important when growth is being spotted at this point to be able to recognize if there's change in curvature. Surgical intervention is done, and which means we have to do long-term monitoring. Assessment include asymmetry of the ribs and flanks, hip height, rib positioning, and shoulder heights as asymmetrical. Radiograph has to be done to assess fully. The intervention include monitor progress of the curvature, prepare the child and parent for the use of brace if prescribed, and prepare the child and parent for surgery. Braces may be used and will need to be prepared for post-operative intervention. The highlight here is potential for alter role performance, body image, disturbance, fear, anger, and isolation exists for a child with disabling condition and a condition that require wearing a brace. Juvenile idiopathic arthritis is also listed as an autoimmune inflammatory disease, and the treatment is supportive. There is no cure, and it includes medication, physical therapy, occupational, child and family education. Surgical intervention may be done, and our assessment is outlined in box 43.2. The interventions include social and emotional support, instruction on medication, and depending on the disease process, it's a stepwise manner depending on the disease response to each level, and that's outlined for us in box 43.3. And the fracture that we have outlined has to do with immobilizing. There are issues with increased result in increased mobility and inadequate or immature motor and cognitive skills. They may result from trauma or bone disease such as congenital bone disease or brain tumor. Fracture in infancy is a note here, are generally rare and warrant further investigation to rule out possibility of child abuse and to identify bone structure defects. We have to look up in the assessment for pain, tenderness, deformity, edema, muscle spasm, loss of function, and crepitation. We describe crepitation so that you can know whether there is a change in the continuity of the bone. Initial care of the fracture, we have to follow our priority nursing action that is outlined in our book under fracture. Please take note of that. And the intervention could be reduction or retention. Traction may be used, and as depending on the extent of the injury or what can be done based on the assessment, cast could be used. But a note here is that if there's a fracture of the hip or knee, may require a speaker cast. Any question on the musculoskeletal? I apologize the rush for those who will be listening to the recording. We have forgotten to do the recording, so we had to do it in a rush. Any question to the group on? Let me look and see. I don't see anything lighted up. So we'll move to infectious diseases, which is a relatively short chapter, and then we'll do the medication. And the human immunodeficiency virus infection and acquired immunodeficiency syndrome, that's listed in if you see there's a fine chart that's listed on page in 7th edition on page 521 as box 44.1, where it outlines the immune system, the specific and non-specific, and as it goes down with all the immunoglobulin. This gives you an idea, so you get a rationale behind why when HIV affects the immune system, what is happening here. Transmissions can be horizontal through, for example, sexual and other means, direct contact, but vertical can be through perinatal. The most common opportunistic infection that occur in children infected with HIV is pneumocystic jirovecii pneumonia. And pneumocystic jirovecii pneumonia most frequently occur between the ages of 3 and 6 months. Now here's a note: an infant or child infected with HIV is at risk of developing a life-threatening opportunistic infection. Monitor the infant or child closely for signs of infection and report these signs immediately if they occur. In the assessment, we have to look at the, for example, Candida esophagitis, crypto. There are several conditions we have to look at from herpes simplex disease to HIV and encephalopathy, lymphoid interstitial. Those are part of what, and even wasting syndrome. But for the 4.1 and 44.2 outline, all you should look at from cough to diarrhea to delay in growth, failure to thrive, liver enlargement, lymph node enlargement, fever, night sweats, oral thrush, weight loss. Now, diagnosis tests are done, obviously. There are several now. Even the Western blot tests have been more, enzyme link tests have been more specific to even identify the strain. And as you will see in table 44.1, the diagnostic test. The diagnostic tests, also before tests, we have to do counseling to be able to, like all of us who have had HIV testing done, counseling has to be done, and it's true of even children, even those whose mothers may have been infected and may have transmitted to the child. The care of a child with HIV infection or AIDS, it's a multidisciplinary care that is taken, and the primary goal is to decelerate the replication of the virus, prevent the opportunistic infection, provide nutritional support, treat symptoms, and treat opportunistic infection. So you want to prevent, and when it happens, you want to treat. The prophylaxis are giving, antiretrovirus medication are giving. Now, a note here that before administering an antiretroviral medication, ensure that the medication is safe for pediatric administration, which we're going to talk about here. Also check the contraindication for use and the adverse effect. Immunization. Guidelines for symptomatic HIV infection or severe immunosuppression are provided so that if a child is HIV positive, what is the restriction or not. But immunization against childhood diseases is, and please know that it's recommended for all children exposed to and infected with HIV, because it also helps them to be able to ward off opportunistic or even seasonal infections. Again, we have to look at caregiver instruction. Part of our nursing role, because as the family goes home, it's good to share with them what they should be doing in terms of, for example, hand washing, taking care of fever. When there is fever, immunization should be up to date. The child needs to be restricted from having contact with people who have infection. Keeping the child home when sick. Avoid direct unprotected contact with the child's body fluid. Monitoring weight, high caloric and high protein diet. Making sure you check for appetite. If there is a need to increase to provide appetite stimulants, that has to be done. And not to share utensils with the child. Make sure you wash all utensils in a dishwasher. Cover the child on used food or formula, refrigerate them, and do not allow the child to eat fresh fruit or vegetables or raw meat or fish, because so this is like a neutropenic diet if immunosuppressed. You have to wear gloves to care for the child because you don't want to cross the infection. Change the child diapers frequently and dispose of trash. There will be time that with the child body fluid, when they spill, you have to use bleach solution. It's 10:1 ratio of water to bleach. And then educate the adolescent infected with HIV on high-risk behavior, method of transmission, importance of abstinence from sexual contact such as intercourse, the importance of using safe condom if intercourse is planned. One thing we have to emphasize with the use of condom is to let them know that they should check the expiration and know how to use it safely. Resources available for support and other issues. I see a light up here. So one thing we should know that a child has contracted this disease from the mother. The disease will present the same in the child as an adult, risk of secondary infection. Thank you for that. Now, let's look at other infectious conditions. Rubella, measles. Make sure I didn't skip. Okay, good. The agents and incubation period, as you go through the book, I'm going to skip some part of it just to get you an idea. The agent is paramyxovirus. The important thing we're going to be looking at here to look at the source of the infection so that we know exactly how to manage and the transmission, of course, intervention. So the person is communicable in rubella, in measles. Measles is becoming a problem even in the U.S. So it's good to recognize it and also teach the community and parents. Of course, there are people for conscious reason, religious reason, who doesn't want to get vaccinated. But we need to continue to advocate for children to get vaccinated because it's becoming an epidemic, I would say. The source of infection for measles, respiratory tract secretion, blood or urine of infected person is transmitted by airborne particles or direct with contact with droplet. It can also be transplacenta. The assessment, as you see, if you look at the photo in for the 4.2, you see the classical sign on the skin. Fever, malaise, then you have the 3 C's. Remember those 3 C's with measles: coryza, cough, and conjunctivitis. The rash will appear red, erythematous, maculopapular eruption starting on the face, spreading down to the feet. It blanches easily with pressure, and if you press on it, it looks like it's getting, it blanches. It gets like light color, and when you leave it, it get red, gradually turn brownish color, and last 6 to 7 days may have desquamation. This is why usually the skin loosening up. Coupling spot. Usually, if there's 1 or 2 signs that you need to look out for measles, will be the 3 C's obviously, but the most differential that is easy to identify, especially when you talk about different races, depending on the manifestation, is the coupling spot. These are the red spot with a bluish white center and a base red located on the buccal in the mouth and lasts for 3 days. Usually, a lot of time when you have difficulty, especially for example, I have seen measles many times, so it's easy for me to identify, but some people who may want to just have something to identify where you see the coupling spots. The intervention would be airborne droplet and contact precaution, quiet activities, and breath, mist vaporizer, and cough for the cough and coryza, dim lights, a photophobic. One of the things about measles would be photophobic, so you have to have a dim light to be able to help them to see better. Of course, something for fever, vitamin A supplement. Rosella is communicable period. It's a hemoherpes virus type 6. It's unknown, the cause is unknown, the communicability period is unknown, but it starts to extend through the febrile stage. And again, the source is unknown, transmission is unknown. So when you have these infectious conditions that everything is unknown about a lot, it becomes difficult to manage them. So you have to do a regular precaution in any infectious disease management. But there'll be sudden high fever. These are how some of the differentials can be tested in your assessment. The fever is so high, it can break and it just jump up very quickly for 3 to 5 days. And in a child who was well, and then you will see this rash, rose pink macula. The rashes appear several hours to 2 days after the fever subsides, and the treatment is supportive. German measles, rubella. The source is nasopharyngeal secretion. Virus is also present in blood, stool, and urine. The transmission is airborne or direct contact, indirectly via articles freshly contaminated with nasopharyngeal feces, secretion, feces, or urine. It's also transplacenta. The assessment is from low-grade fever, malaise, but characteristically, you see pinkish red maculopapular rash that begin on the face and spread to the entire body, and they start to have red pinpoint spot petechiae on the soft palate. We, as part of the intervention, is to use airborne droplet and contact precaution. Figure this out, most of these infectious diseases, especially when a child is hospitalized, you do your regular airborne and and contact precaution until the signs are definitive or the incubation period has ended or the communicability has ended. Isolate the infected child from pregnant women. I know you know about the touch diseases. So when a woman is pregnant and they have one of these diseases, you want to make sure that they stay far away from. That's why nurses that are pregnant are usually, made not to care for these kind of patients. Mumps, again, mumps is common in society. Pretty easy to manage if it is taken care of well. Its communicable period is immediately before and after the parotid gland swelling begins. Saliva Saliva of infected person and possibly urine as sources can be transmitted direct contact or droplet from an infected person. You want to assess for headache, fever, malaise, anorexia, and a jaw pain. That's usually characteristic of the jaw pain. And one of the things that stand out with moms is orchitis. They start to have the testicles inflamed, followed by, and in the case of the jaw and ear pain, it will be aggravated by chewing, followed by parotid glandular swelling. So usually if they're asked to open their mouth and they check their parotid gland, or even you palpate, you could feel that. Intervention, airborne, again, precaution and contact precaution, bed rest, avoid foods that require chewing, apply hot or cold compress as prescribed to the neck, warm compress, and local support with snug fitting underpants to relieve orchitis. Monitor for signs of aseptic meningitis. One thing to add on here is that know that a child can contract this disease from the mother. I'm sorry, the mother. Okay, so and also note that in the time that we're talking about the skin condition, the integumentary, so some of these conditions were showing as well. So this is why we're running through them. You can go back in the textbook and check on those to see them. And also you can look at the picture. NCLEX may present a picture of the disease along with the scenario. So if you look in the book and you see measles, especially conditions like measles, they are going to show you a picture, and those pictures will be distinctive in your alternative questioning. So like chicken pox, those are the common ones you will see a lot: measles, chicken pox, and some other conditions that you. So take note of those photos, and remember, if what you could do also, you can go to Google image and Google in the image and say how does measles look, how does this condition look. So if you see it on an NCLEX, it's easier to identify. Thank you. Chickenpox, varicella zoster virus. The source is respiratory secretion of infected person, and the skin lesion is transmitted direct contact, droplet, airborne, spread, and contaminated object. In our assessment, we want to look for fever, malaise, anorexia, followed by the macular rash that first appear on the trunk. So if you look at 44.5, you see a typical sign of chickenpox on the face, as you see. Lesion become pustules, begin to dry and develop a crust. Skin lesions may appear on the mucous membrane of the mouth, genitalia, and the rectal area. Our intervention in the hospital, we have to ensure strict isolation, contact and droplet airborne. At home, isolate the infected child until the vesicles have dried. Once it dry up, usually the virus is on. Antiviral agent, Iscavir, may be used to treat varicella infection in suspected immunosuppressed persons, to decrease the number of lesions and shorten the duration of fever, itching, lethargy, and anorexia. The use of VCZ immunoglobulin or IV immunoglobulin is recommended for children who are immunocompromised as well, who have no previous history of varicella, or who may likely contract the disease and have complications as a result. Provide supportive care. Remember, this is a virus condition, so a lot of time you treat the palliatively. One thing to note here is that we have already said that is that isolate high-risk children, such as children who have immune suppressed disorder from a child with communicable disease. Stay far away. Whooping cough, pertussis, Greatest communicable period is greatest during the catarrhal stage, which is when the discharge from the respiratory secretion occurs. And the source is discharged from the respiratory tract. It's transmitted through direct and droplet spread from infected persons in direct contact with freshly contaminated object. In our assessment, we want to look at the symptoms of respiratory infection followed by decreased severity of cough with a loud coughing inspiration. Whooping cough is very characteristic with the loud whooping inspiration. Oh, and they will cough very hard. May experience cyanosis, respiratory distress, and tongue protrusion, listless, irritability, and anorexia. So again, this is one of the sounds you should look for. Listen on YouTube about the sound of whooping cough. Listen to it and you will know that it's characteristic. Please write it. The intervention, you have to isolate the child in that catarrhal stage. If hospitalized, of course, institute airborne contact precaution. Antimicrobial therapy may be prescribed. Reduce environmental factors that cause coughing, spasm, so adult smoke. Ensure adequate hydration and nutrition, suction, and humidify oxygen if needed. Monitor cardiopulmonary status and make sure you check the pulse as often. Infant do not receive maternal, take note of this, infant do not receive maternal immunity for pertussis. The DPT, tetanus, diphtheria, exular pertussis, Tdap vaccine should be administered to women in the postpartum period and those in close contact with the infant to prevent spread of pertussis. So please take note of that. Diphtheria. This is cyanobacterial diphtheria. In this is communicability, it varies. The source is a discharge from the mucous membrane. Let's see if we have a note here. From the mucous membrane of the nose and nasopharynx, skin, and other lesions of the infected person. It's transmitted through direct contact with infected person carrier. Know that diphtheria has a carrier, it's a bacterial infection, or contaminated articles. We have to assess for fever, malaise, sore throat, foul smelling, micropurulent is the discharge. Dense pseudomembrane formation in the throat that may interfere with eating. So the tissue appears to be growing, even though it's considered a pseudomembrane, but the tissue is growing. It's probably related to some inflammation, and that can interfere with eating, drinking, and breathing. Lymphadenitis, where the neck edema, and they look like they have a bull neck. The intervention for diphtheria, strict isolation for hospitalized child, diphtheria antitoxin, provide bed rest, antibiotic, suctioning, and humidify as needed, and provide tracheostomy care if a tracheostomy is needed. So you can see that this could cause, to the extent that it will cause occlusion. Poliomyelitis. We know this is quite a debilitating condition. It's supposed to be wiped out in many parts of the world, but we are noticing that we are in a global community, so it won't be unusual that we'll have this come back, even in industrialized country. The communicability period is unknown. The virus is present in the throat and feces shortly after infection and persists for about 1 week in the throat and 4 to 6 weeks in the feces. Oropharyngeal secretion and feces are the sources, and is direct contact with infected fecal oropharyngeal route. Assessment, again, as they are related, fever, malaise, sore throat, or abdominal pain followed by soreness and stiffness of the trunk, neck, and limbs. That may progress to central nervous system paralysis. Our intervention will include enteric and contact precautions, supportive treatment, bed rest, monitor for respiratory paralysis. This is what really puts polio, apart from the other ones as well. And of course, there will be weakness in the extremities, but the respiratory paralysis is an emergency or is a situation that can lead to much more grave consequences. Physical therapy is done. Scarlet fever, we'll browse through that a little bit. The source is nasopharyngeal secretion of infected person and is direct transmission with an infected person or droplet, or articles or injection of contaminated milk or other food. The assessment is in 44.6 rather, figure 44.6. But what to look at there is the intervention, institute contact precaution and respiratory precaution until 24 hours after you start the antibiotic. Treatment is supportive. What is called erythema infection sum is a febrile disease. To note about that is the assessment before rash is symptomatic or mild fever, and then by the time the rashes show on the face, it's considered like slap cheek appearance. So you have this redness that looks like somebody was slapped, develop and disappear about 1 to 4 days. The intervention, the child is usually hospitalized. Pregnant women should avoid infected individual, and we provide supportive treatment, including fever control, pain, anti-inflammatory medication. Infectious mononucleosis is caused by Epstein-Barr virus. Direct intimate contact. One of the things to look at here is lymphoedema, lymphadenopathy, and hepatosplenomegaly. In addition to the other constitutional symptoms that we see with headache, fever, malaise, abdominal pain, sore throat, enlarged tonsil. It's also discrete here. It has a discrete macular rash, most prominent over the trunk, may occur. But also, you should know that a lot of people wouldn't show symptoms and they can even go away without having a prolonged time of showing symptoms. You should provide supportive care, monitor for signs of splenic rupture. You should teach the parent of a child with mononucleosis to monitor for signs of splenic rupture, which include abdominal pain, left upper quadrant pain, and left shoulder pain. This is where they have to know where the spleen is located, so that if they notice any unusual bulging, they can report that. Rocky Mountain spider fever. The source is a tick from a mammal, most often from wild rodents and dogs, transmitted by bite of infected tick. Again, there will be a maculopapular or petechial rash, primarily on the extremities, the ankle and wrist, but may spread to other parts, characteristic on the palm and the soles. Our intervention will be to provide vigorous supportive care. Antibiotic, teach the child and parent about protection from tick bite, and that's in box 44.3. This is one condition we should take note of, MRSA, in this case, community associated. So we'll look at this a little bit. Person at risk for community acquired MRSA include athlete, prisoner, daycare attendees, which of course happen to be children a lot of time. Person who abuse intravenous drugs. And if we have a family member, other things who abuse drug and the child is exposed and there's wound, this is where the acquired one comes in. So it's spread through person-to-person contact, through contact with infected item, or through infection of a pre-existing cut or wound that is not protected. The bacteria can enter the bloodstream through the cut or wound and cause sepsis, cellulitis, endocarditis. Now we're talking about a cardiac condition, osteomyelitis, septic arthritis, toxic syndrome, pneumonia, organ failure, and death. This is why there is a lot of attention on MRSA to make sure it's prevented, and for health workers to be also assessed for that. To prevent it, often do good hand washing and practice good hygiene. Avoid sharing personal items, regular cleaning of shared equipment such as athletic equipment, whirlpool, or saunas. Children get a lot of infection from sharing equipment, especially in school, from scabies to now you see MRSA. Cleaning a cut or wound thoroughly, and in assessment, you have to look at appearance of a skin infection, red, swollen area, warmth, and around the area. I mean, to digress a little bit, this is one of the questions when it comes to MRSA or wound that could be considered a problem, and even a nurse or a staff, is that when you have an unusual red swollen area on the skin, one of the things to rule out is whether the person has an infection with MRSA, especially when it's a wound and it has issue with healing. So take note of that. I need to look at a version of how the question comes, but I've seen that in a couple of NCLEX practice questions, and in infectious disease testing, to make sure that if a staff has wound of this color, that it should be assessed, is considered to be assessed for MRSA. So warmth around the area, drainage of pores, pain at the site of fever, and the symptoms of a more serious infection will be chest pain, cough, fatigue, muscle ache, shortness, breath, and the rest of them. The intervention is to assess the skin lesion, prepare to drain an infected skin site, and culture the wound. It's very important to culture and the wound drainage, because if it's culture, it can be more specific to know that it's MRSA and what can be done, and the type of medication, so that you don't have medication being used for so many things that repeat. Prepare to obtain blood culture, sputum culture, and urine culture, depending on the location. Some MRSA are colonized. Some people have history, but it should always be on their chart with the children to know history of any kind of MRSA. Prepare to administer antibiotic. Then these are specific antibiotics for MRSA. Educate the child and family about the causes and mode of transmission, signs and symptoms, importance of treatment as prescribed. Influenza, this is common, we all know, and it's a virus infection. Children, pregnant women, persons with existing health condition, and persons with a compromised immune system are at risk for developing complications. Is contact with an infected person spreads this, and it's caused by that, and by touching something such as toy, tissue that infected person touched. The big prevention on this is flu vaccine. Every year should be given. Wash the hands of the child frequently and teach hand washing techniques, because they are touching dolls and toys and everything, especially those that have to go to school. You know, the season comes when all the children have flu. Avoid children who are ill, meaning even if your own child or the child that you know that is in your care should not go to school or in public places when they are sick. Keep the child home from school until they are fever-free without use of antipyretic for at least 24 hours. And the CDC have a lot more information that you can look in the website. The signs and symptoms of flu usually last a week. If they last longer, the presence of complications should be suspected, which means in our assessment, we should look at fever that occurs suddenly and is high, headache, body ache. The same symptom we have as an adult with flu, which many of us may have had. You can think about that with the children who are complaining of the sore throat. Appetite will be lost, and they will vomit, diarrhea. Intervention, antiviral medication will be prescribed. Usually they are not considered a mainstay. Now they have some good ones, but often fluid, rest, pain reliever, fever control are much preferred. Family and teaching of the child about preventative measures is very important. Immunization. We're going to gloss over this, but very important. When I say gloss over, we're listing out every schedule you should be aware of, because there are age-appropriate immunization that you really should take serious to take note of. And if you look at the guidelines in the priority nursing action for immunization, it outlines what should be done. And in the guidelines for administration in box 44.4, it depends on the procedure that have already been set. Children born preterm should receive the full dose of each vaccine at the appropriate chronological age, at their actual age. The recommended childhood and adolescent vaccine, adolescent immunization is in box 44. You will see that in box 44.5. Please take note of those because you are going to see schedules like that in every assessment to be able to know which vaccine is good at what age. In the priority nursing action that I mentioned about is on page 528 to guide us about vaccine administration. And also take note of reaction to vaccines because depending on the type of chemical, I know there's a big scares of some people who feel that because of certain chemical in vaccines, so we have, they are refusing vaccine and also sending out a lot of information that are not corroborated by research. So take note of that, and also always tell the family that there will be a reaction sometimes, or there's uncomfortable sites when the vaccine is given. We all have had those feelings. All right, any question on the infectious diseases, infection and communicable diseases? I don't see anything light up. Okay, so let's take the next, hopefully 15 to 20 minutes. Sorry, 15 to 20 minutes to finish up the calculation, which some of it we have done. Okay, all right. So pediatric medication administration and calculation. Let's look at them in two categories.
Can I jump in?
Sure.
Dr. Dollar, do you have me on mute?
I'm sorry? Oh.
Can I just, because I think I'm going to lose my data. Can I just mention that I need for the students to.
Go ahead. Did we lose you?
No, I'm here. I'm here.
Okay. Okay.
Can you please just have everyone look at the new due dates for the assignments? I can't readjust them. I did speak with Canvas, and those will be the closing dates of the assignments. There's no more adjustments to be made.
So everybody take note of those. And for those who also have problem with that, I think, yeah, thank you. I saw the adjustment last night. Time adjustment. Okay, thank you. All right, thank you. So we'll lose you, then we know you're gone. That's it?
Excuse me. May I interrupt for a second? I just want to make sure that final email with the due date is the permanent due date for Canvas.
Yes, that's what she's saying.
Yes. So I just posted the final due date. There won't be any changes.
Okay. So we can ask questions about that if you stay on, or you can ask me. I will look on Canvas to see what we have there. All right. After the next 15, 20 minutes. So chapter 45, again, we're going to look at this medication administration and calculation in terms of two categories, oral and parenteral. In the oral pediatric medications, they come in the liquid or suspension form because children usually are unable to swallow a tablet. The solution will be measured using an oral plastic syringe or cup or some other administrative device, and you can see that in figure 44 when there are several cups and tubes and other things that are used. So how to administer oral medications are outlined. I know most of you may have done that, but there are guidelines about the positioning of the child, what to administer with. Sometimes there will be time you may have to do some administration to increase the taste better. So follow generally accepted medication administration guidelines for children, and those are in box 45.1. Newborn and infant have an immature liver and immature kidney. Therefore, metabolism and elimination of medication is delayed. So we've got to be careful when we are administering to them. So in the case of guidelines for children, for example, 2 identifiers are required before medication administered, such as name and record number and birth date. Barcode scanning is good. Obtain information from parents about successful method that administer medication for their children. Ask parents about any known allergy. To avoid aspiration, liquid forms of medication are safer to swallow than other forms. Straw often help older children to swallow pill. Avoid putting medication in food such as milk, cereal, or baby food because it may cause an unpleasant taste to the food and the child may refuse to accept the same food in the future. In addition, the child may not consume entire serving and will not receive the required medication doses. If the taste of the medication is unpleasant, it is acceptable to have the child pinch the nose and drink the medication through a straw. Offer juice or soft drink or frozen, like I explained that. Always read the pharmacological indication of administration. Some items such as fruit syrup can be acidic and should not be used with medication that react negatively. Record the most successful method of administering medication and pertinent nursing prescription on the child's care plan for other nursing staff to follow. This notation also saves the child frustration, fear, and anxiety. Please work as a team. It's very, very important. Some people know very well how to save medication to that particular child, and the other nurse come and have so much trouble. Now, so that was about the oral medication. The parental medication, I want us to break them out into series, but look at them as subcutaneous and IM in one category, as you can see in the slide here, and then look at them as intravenous, and then you have them in several special categories. So the subcutaneous, there are different sites that you can use, and they are outlined in the book. I mean, you have gone through these medications, so we mention them here so it can give you an idea of how to align them. But if you have done this, we did this in calculation and other places. So the safe use of medication site is based on normal muscle growth and the size of the child. The preferred site for IM in infant is the vastus lateralis. Keep that in mind. Keep that really deep in mind. But agency policy and procedures need to be followed. But a lot of times, agency followers tend to go back to the guidelines, and then they will give you an alternative if you don't get a vastus lateralis. The child has a deformity or has some fracture or some issue, or have had so much in one place, do this, you know. And then you also have to look at the needle length and gauge. That depends on the age, the child, and muscle growth. That's about the sub-Q and the IM. In the intravenous administration, they are often diluted for administration because of their constitutional status. Remember, they highlight our list there about their metabolism. So usually they are diluted to be given over a period of time. When an infant or child is receiving an IV medication, the IV site needs to be assessed for signs of inflammation and infiltration or extravasation immediately before, during, and after completion of each medication. Please, children have lost limb because of not checking on time, and they don't have the luxury of time that adults have to be able to withstand certain insults to their body. So if there's an infiltration, it could damage a whole tissue, or your immediately so blew up, you will just feel, what happened. This is why you need to check a lot of time with IV medication. Flow rate, flush, prescription, and agency policy should be followed, depending on the type of medication, depending on the size of the child. Even the location of the IV site can determine what should be the flow rate, and almost every medication for children has to have a flush set for IV because they need to be flushed at an intermittent time. Intermittent IV medication administration are also done for them. This is why sometimes the line is open and it has to be flushed. Special IV administration set are usually used for them depending on the type of solution. Depending on the type of medication, you may have to use a filter. You may have to use even double filter, depending on what it is. So take note of these when you have to practice, and also when you have to take a test. There will be syringe pump for IV medication administration. They come in different form. Electronic pumps have made it much easier, but they still have to be set. Some are set double, to be able to make sure that it runs into one and it runs into one. So especially for children. The note here is 24-hour fluid intake must be monitored closely, and all IV fluid amounts, including the amount of flush volume, need to be documented accurately to prevent overhydration. For children, the maximum amount of IV fluid administered in a 24-hour period varies and is usually based on body weight and other factors, which we'll soon talk about the BSA. Check the provider prescription and agency guidelines for the procedure for the administration of IV fluid medication. Calculation of dosage by body weight. We're not really going to go into this because it's not practiced as much. I'm sorry, I'll take that back. It's the other one. To convert body weight is really done as often. I'll take that first of all back. Now, if you look at box 45.2, what we see here is measurement in terms of conversion of weight to ounce, pounds to kilogram, pounds, and kilogram, and vice versa. So we have to do that. We did that in module 1, so we don't want to repeat conversion of body weight, but we have to take the body weight and we have to convert it. Calculation of daily dosage and the abbreviation that we have to use is in 45.3, where we look at, please take note, we saw that in some of the even though the module 1 draw calculation, we kind of was glossing over, because you have to always put a unit. It's very important. The unit can make a big difference. Some errors have occurred because people are using, because imagine the difference between a microgram NCG and an mg. It's a lot. It's not even small. It's not even something to look at. So you have to put it. I know some people, depending on their preference, they could use the word cc or milliliter. It's up to you. But whatever your facility wants to use, keep at that. This is why in many, for example, I just digress a little bit. In routine services, like in wound care, people want you to be consistent to use, for example, centimeter. If you really have to use millimeter, it has to be in such a way that it's so small that by saying 0.1 or 0.6 cm can be a difference. So you have to follow those routines. Very important to maintain abbreviation based on the standard. The calculation of the body surface area is the one I was talking about. It's usually, those are usually given you, so it's not as commonly used, but it's good to know them because you will be confronted in some advanced practices that you will do, or some of you will want to go into certain kind of certification in certain kind of care from neurological to even burn, and you have to use some body surface area formula. So it's good to know them. You have to look, in this case, not all children are the same size and age. The nomogram is used to determine BSA of a child. If you look in 45.3, it's actually listed there. So if you haven't ever practiced it, you can look at it and it gives you in fact, there used to be, even in some facility, there is a little chart that you can use. You can measure this. It's like a little grill that you have and can help you to determine that. So it's not unusual that you'll get measurement and also piggyback medication administration. The special pumps that I talk about. So we also have to remember our piggyback, where one fluid is hung and another one is hung to be able to flow into another one. Usually it happens when you're taking certain kind of medication and there is another fluid that is helping to cover, or you're giving an antibiotic and that has to be done with another fluid. Thank you. So calculation of BSA, based on BSA, like I said, you can read on that too. It's a complicated calculation, but it's usually a formula is given you and you can use it. There are some medication, I've seen recent medication that there was a medicine recently, and it was a respiratory medicine. I had to help a client to to calculate. There was no way to calculate. The only way that this new medication has come, you have to do BSA. So I had to refresh my skill right there and there. So developmental pediatric, I mean, continuing this, developmental consideration for administering medication is very important to understand that depending on the stage of the child, you have to be prepared to be able to administer medication in a different way with different consideration, from infant to toddler to preschool. I know this look like something that, oh, it's obvious, I should know this, you should know that, yes, you should know it, but you should practice it. It's very important. You will, when you try to practice with children or different age group, you will get to realize. And think about this too as adult citizens. At some point, you may have to change your paradigm about giving medication based on certain developmental stages, or in this case, even the age, and from infant to everything else in between. Okay, look like that's it. Thank you very much. I'll go back. All right. Any question? This is it for the day. Thank you for the patience. We actually were able to do all of this in 2 hours, 2.5 hours. There's a lot to cover. Any question, comment, insights? Yeah, 42 person on. You can
This
unmute
is
yourself.
Lynette. I don't have anything, just to remind them to look at the assignments, for them to remember that payments were due on the 1st of the month. And I believe Stanton wanted to make announcements. I'm not sure if he's available or if he still has anything that he wants to add.
You can be talking to him. Let me get him. So, and anybody who have a question, the line's open. I'll be ready.
So for those of us who normally meet on Saturday morning, or is that Sunday morning, I won't be available tomorrow morning. However, I will be available tomorrow in the evening. I'm assuming we can do something somewhere around 4 o'clock. If you're available, I will be online to do Q&A like I normally do on Saturday. I hope it's not too much of an issue, but the time difference for where I am doesn't permit me to come any earlier. So I hope to see as many there as possible.
Okay.
Thank you, Latrell. Thank you very much. You're welcome. If you have specific things that you'd like to cover, please send me a message in the inbox on Canvas.
Okay. All right. He's a little busy, so I will. Was somebody on?
Yes, I'm on.
Yeah, Miss
Okay.
Lynette
I
is
didn't
on.
want to interrupt. Okay.
That's okay.
Okay.
Do you have a question, Sally?
Yeah, can I call you by individual?
I'm sorry, you call me. Can you inbox me on Canvas, Sally? You can text me for like the next 20 minutes. I'll be able to get text. Other than that, you'll have to inbox me on Canvas. I'll be able to go online. It's slower.
I'm gonna end the recording now. So, and then should I end the recording now? Or
Do
not?
I?
Okay.
Yes, thank you.